So good morning, everybody. Today is going to be a long day as well. I'm going to try to stick to the schedule, but there might be some deviations. You just have to bear with me on that. It's not that I have not prepared, but I'm going to vary a little bit the presentations as compared to the titles, because I think there's something that has come out of the conversation that I've had with you that makes me feel that we need to emphasize different points of medical writing and clinical research that have changed a little bit the program, but it's not a big problem. Don't worry. Today, I'm going to start out with what critical appraisal is, how to do it, and how that intervenes in writing a discussion. If you remember yesterday, when we talked about the discussion, we said the first paragraph is the answer to the question or the hypothesis that we raised at the end of the introduction. After that first paragraph, we have to place what we found, the results of the study, as it pertains to the literature. What have we found? Is it the same that somebody else has done or found? Is it different? And if it's different, why, in our opinion, the writer's opinion, do we think it's different? Once again, just a few examples. In our study, we studied men and women. In the other study, they only studied women. We studied patients between 15 and 25 years old. The other study included patients up to 80 years old. All these criteria enter into what we call critical appraisal. But critical appraisal is a little bit more than that, because it's also searching for what we call evidence. The problem is that evidence in medicine is not evident. In other words, it's not that obvious. And it has to be we have to be able to qualify and to quantify what we're talking about. Qualify is a little bit just what I just said, but the quantification is something that depends on statistics. We just, once again, as I said yesterday, we cannot get away from what we talked about yesterday in statistics and the types of study. We have to really put ourselves on a workhorse and try to understand if we are talking about something that is just an association that has happened by chance. It's very important, the word chance, hazard, if you like, and something that has a cause and effect. In other words, because we smoke, we get pulmonary cancer. Okay, very important. Qualification and quantification of what we call evidence. Why? Because we are in a world of uncertainty. Remember the citation of William Osler that I gave you yesterday. We cannot affirm, we cannot say, because I do something, this is the truth. Now, I am speaking as a more elder person than most of you. At one time, I was in your seat. I was in your pants. When I had more senior people over me, working over me, telling me, this is what you should do. I asked why. The reason was always, because that's the way I do it. Now, there are bosses, there are seniors still today, not only in Russia, but all over the world, that still believe that what they have learned, what they practice, is the way to go. I'm not criticizing that, other than the fact that it has to be combined with the possibility of accepting that dogmatism is not the correct way to demonstrate what should be done. You have to accept what we call uncertainty, but we have to quantify to what degree that uncertainty stays on the surface. I'm going to talk about this in terms that you have heard about yesterday. Bias. I hope you understand the word bias. Can my translators tell me if they understand what's the word in Russian for bias?
Yes, I do understand. Yes.
Okay. Bias exists everywhere in medicine. Biases exist everywhere in the world, even in politics. But bias is the danger that hovers over our heads when we read the literature, when we try to understand what is being taught by other people. Bias is something that you have to realize is the way people select what seems to be the best in their opinion. In other words, a way of thinking, but not looking at how that idea, how that technique, if we're talking about a surgical technique or an endoscopic or a radiological technique, how that idea, how that technique was derived. There are people that are extraordinary. Let's take the example of Enrico Fermi. I don't know if you've heard of Fermi, who was a friend of Albert Einstein. And one day he came up with a constant, which is called the constant of Fermi, for astronomical calculations of how far the stars are away and how the Earth rotates around the sun, and a lot of things that we know today and we take for granted. And he said, yes, and the equation that I am putting forth there's a constant, and this constant is 1.555333. So there were 375 digits. I'm just making up 375 now, but there was more than 100 digits. And he put it on a blackboard in a classroom. I believe it was he was Italian, so it was in someplace in Italy at that time, before he moved to the United States. And people started saying, oh, this is Professor Fermi says this, we have to do this. And then people like Einstein asked him, where did that come from? How did you calculate it? He says it came in a dream. Yeah, so, and it's true today. I mean, we still use that constant. So there are people that are exceptional, but most of the people in medicine are not. So there are myths that have been passed down from generation to generation. And something else that has intervened in our, let's say, hierarchy of teaching. And I must say, I've lived through this, and this is an idea that I'm trying to pass down to you, is that we as doctors, as professors of surgery, do not have any training or any formal training in what I'm talking about today. We don't have any formal training how to teach. We are teachers because we have to teach, because people younger want us to teach, because we have to pass down the knowledge, the experience, knowledge and experience that we have acquired over the years. However, many of the teachers, so-called teachers, teach what they have learned when they were students and young physicians, and do not keep up with the literature. And when this happens, obviously, there is a bias. Last but not least, there are a core of teachers that do read the literature, but they pick out of the literature what goes in their direction. This is called cherry picking. Cherries on a tree, we pick them up, we pick up the ripe ones. The ones that are rotten, we leave alone. And it's come also to another idea, which is called spin. It comes from the idea that politicians always try to find a reason to get elected. They're going to say, well, we're going to build a school here. We're going to build a road here. We're going to lower the taxes. We're going to do this and that. They don't do it, and they never had the intention of doing it. But they tell those who are the possible electors that this is what they want to do and this is what they will do. The same thing happens in literature. In let's say, lots of professions, not only medicine, not only surgery. But because somebody has an idea, he looks into the literature and finds only things that go in his direction. So this is spin and cherry picking. Now, how can we get by? How can we overcome? Well, A couple of years ago, a Canadian called Sackett, David Sackett, who passed away, I guess, maybe a little bit more, maybe, let's say between 5 and 10 years ago, who was working in Canada, as I said, came up with an idea that you see abbreviated EBM, evidence-based medicine. And he tried to define, I think I'll talk about the definition in a little bit in a few minutes, of a way of a reasoning, of a logic to help eliminate the cause of bias. Bias is just human nature. I'm not going to be overcritical. We all have biases. We are not born with biases. We learn biases from our parents, from our school teachers when we're young. Some of them are true, but they are biases before they become truths. So evidence-based medicine is one of the basics of trying to eliminate most of the causes of bias. And something that's very important, that it is a tool that promotes consistency. Very important word, consistency. In other words, Mr. So-and-so does a surgery he's cutting 2 centimeters from the pylorus. Mr. So-and-so, another so-and-so, says, no, it's not 2 centimeters, it's 2.5 centimeters that you have to do. It works. Both work. But one says, this is 2. The other says, no, it's 2.5. And then, because of the variation, somebody's going to do it at 3. Maybe it'll work. But then somebody's going to do it at 3.5. And it doesn't work. So you see, the variation that people think and get away with sometimes can lead to inconsistency of treatment, and therefore optimal outcomes are lost. Another quality of evidence-based medicine is that it helps establish national standards of patient care. Guidelines, for instance. Guidelines are basically the result of a review of the literature, of the evidence in the literature, a discussion among experts, but based on the literature and based on what we call evidence-based medicine that I'm going to talk about. Now, once again, my slides are mainly on surgery, but you will see that they apply to most of the domains in medicine. We're now going to talk about what we call effectiveness and efficacy. I touched on the difference between them yesterday. And let me just remind you that efficacy means that something works when you do it as an experiment, or as a primary, let's say, a primary operation. Primary meaning the first time you do it, not primary in the sense of being important. It works. Okay? But that is different from effectiveness, because effectiveness means it works for not only when you did it that first time, but it works every time you use it. And when something is ineffective, after it works, after the efficacy has worked, it's very difficult to prove and even harder to accept that what worked once doesn't work for everybody. And this is the difference between efficacy and effectiveness. And because of the efficacy of an initial treatment, people hear about that. It goes on the news. It goes on the television. Everybody understands that something has happened. It's a sensation. And they expect to be able to take advantage of the same benefits that they saw. But before something has been proven to be effective, after its efficacy, is what we have to do and what constitutes evidence-based medicine. There's another aspect that leads to ineffectiveness, and that is that we say to ourselves, because of the pathophysiology of disease, we can do something that seems logical to take care of, for instance, heart failure. Well, all we have to do is take care of the cardiac rhythm and give beta blockers. That would be a good idea. For instance, if we have somebody who has tachycardia, well, then just slow down his heart and then everything will be okay. Or somebody who's bleeding, all we have to do is give crystalloids. Or somebody who has a scaphoid fracture, if you put him into a cast for 9 months or 6 months, he's going to have his hand is going to be completely useless. So just mobilize. Don't do anything about the scaphoid. Things like this are based on pathophysiology, but not on effectiveness. There's another example that we know that I'm going to bring forward here in evidence-based colonic surgery. For many years, people talked about mechanical preparation, but there's no evidence in favor, or there's little evidence in favor. Putting a drain into the abdomen after a colectomy. All surgeons at one point of their life, they put a drain in after an operation. Draining in colectomy, for instance, has been perpetuated for more than 100 years, and people still do it. However, well, they believe it. If there is a leak, the intestinal contents will come out of the drain, and we will have proof that there's a leak. Okay, this may be true. However, all leaks don't go out to the drain. So what are we talking about? We're talking about the false negative aspect of drainage. When intestinal contents come out of the drain, true positive, we know that there's a leak. If no intestinal contents come out of the drain, we cannot say that there is no leak. It's not because there is nothing coming out that there is not a leak. The drain is not working. Putting in a nasogastric tube after surgery, because the physiopathology has been taught to us that after surgery, the gastrointestinal tract motility stops. It has been shown in rats, it's been shown in animal experiments. So there's a problem. The stomach secretes acid. Let's get rid of it. Make sure that the patient doesn't vomit into his lungs and things like that. That's why nasogastric tube was always put in. Maybe years ago, when anesthesiology was in its nascent elaborations, this was something that could happen. But we know today that there's no reason to leave a nasogastric tube in a patient who has an uneventful operation and where the anesthesiology has worked perfectly. When he wakes up, he will have no problem with gastrointestinal motility problems. The same thing when I was a young resident, patients were fasted before the operation, and they were left fasted for 1, 2, 3, sometimes 5 days after the operation. Because the pathophysiology, once again, led us to believe that it would be dangerous to feed patients after an operation or after an anastomosis. We know today that these are beliefs that have been handed down from generation to generation, but they have to be, we have to teach that they are beliefs, that they are not based on what we call truths. However, in practice, very interesting. Even though mechanical preparation by PEG at the time, in the specific study, I don't remember exactly the year, several years ago, still 75%, 3/4 of the population of the French Society of Digestive Surgery that was asked, do you prepare your colonic surgery patients with PEG before the operation? 75% did, although there had been at that time proof that it did not matter whether you use PEG or some other type of preparation. PEG, for those of you who do not know, is polyethylene glycol. The same thing for drainage. There have been several randomized clinical trials that have shown that drainage or omitting drainage does not perjure the patient. Leaving a patient after colectomy without a drain, if he has a fistula, the outcome is not statistically significantly different than a patient who has a drain. Overall, in a trial that had several hundred patients, not one trial, but several trials. Still, 40% of the population of surgeons at that time left the drain. And today, in France, I am sure the same in Russia, at least half of the surgeons still leave a drain after colectomy. Now, there may not be anything wrong with that. However, if you want to send the patient home, he doesn't want to go home with a drain. There are wound care problems that have to be taken care of. There's a lot of consequences of leaving a drain that may be avoided if he does not have a drain. So just those two examples, 70% of the patients, of the surgeons in that inquiry still left their patients fasting after an operation. 46% still put a nasogastric tube and left it in for days and days and days in conjunction with the fasting that I was talking about. So evidence-based medicine is out there. Now we have to make people believe it. Big problem. So how do you do that? How do we do that? That's what we're going to talk about. We have to find a way of guaranteeing the quality. And that is something that I'm going to try to elaborate. But first of all, we have to know what quality means. And there's a saying that doing the thing right is not enough. It's also necessary to do the right thing. In other words, it's not the way you do it, but it is why you do it. And even though experience has its importance, Oscar Wilde said that experience is a name one gives to their own mistakes, which is true. Yeah, but you have to learn from those mistakes. And people are very reluctant to talk about their mistakes. But this has to be something that is the basis of what we teach. And for instance, people have done extraordinary, strange things and got away with them. For instance, in the early post-World War II days, very famous neurosurgeons came up with the idea of doing a lobectomy to get rid of intractable pain. Lobectomy, of course, you know, if it's well done, it doesn't work. But if it's not well done, you have a lot of consequences of going into the brain, especially in those days. And people were maimed just because of a lobectomy that had no effect whatsoever. Or the idea that sympathectomy could cure hypertension. And sympathectomy, even lumbar dorsal sympathectomy was practiced for years and years and years afterwards to take care of arterial disease. Because once again, based on the pathophysiology, it seemed logical to get rid of the sympathetic effect on blood vessels in order to get rid of hypertension. People even came out in the 1950s, once a gastric ulcer was detected, they got a gastrectomy. And even into the end of the 20th century, surgeons were still performing gastrectomy for ulcer disease. And we all know today that ulcer disease can be cured by simple drugs. Even worse, one of the most famous, I'm not so sure that he published this, I'm sure he published this, but I don't have the reference. When somebody had a bleeding gastric ulcer, they put a nasogastric tube in and iced with cold water the stomach until the bleeding stopped. Yes, the bleeding stopped because the patient died. Okay, this is a citation from Voltaire. The art of medicine consists of taking care of the patient while nature takes care of the disease. Albert Einstein, as you know, was born in Europe before he went to the United States. And at one point of life, he went to work in Bern, in Switzerland, beginning of the 20th century. He was a brilliant mathematician already, a young man, but he worked in the mayor's office of Bern in a particular job. His particular job was to look at the patents that people put forward to the mayor saying, well, this is a new way of doing, making shoes, for instance. And they wanted their idea to be protected. This protection or patent exists for many, many years. And the job of Einstein was to say, okay, this is based on solid evidence, or this is not based on any solid evidence. In other words, separating the wheat from the chaff and trying to determine whether this person or this idea should be patented or not. And he was one of the first people to say, well, we have to have some sort of proof that things are working. Otherwise, we just can't go out and do it. But once again, he was one of those geniuses. And that was that he was able to foresee things in physics that other people were just incapable of understanding. So, as I said, we have to come to a definition of what we call critical appraisal. The definition that I've put forward here is one of many, but this is the one that I feel is the best and has been approved by many, many other people. And it's the process of carefully and systematically examining research to judge its trustworthiness its true value and relevance, but in a particular context. Very important. The trustworthiness or the value or the relevance of a technique, of a drug, of a way of taking care of people has to be put into a particular context. In other words, the patient has to be assessed. Remember, it's not doing the thing right, but it's doing it rightly in the right context. So critical appraisal is an essential skill for what we're trying to put forward. We want to determine if what we call the methodology of research, how the research was done, if that methodology is sound. That means that the information is reliable and trustworthy. And whether the results, once again, as I just said, are applicable to the patients we have to treat. The particular context in which we treat them and for which they treat them. And this is sometimes called external validity. Critical appraisal is the way we go forward to decide if what we read in the literature is sufficiently good, sufficiently sound to take part in the decision-making that we do every day to take care of our patients. And closing the gap between research and daily practice means transforming, or let's say validating, efficacy into effectiveness. I believe we have a definition of effectiveness, efficacy, and effectiveness that has to be put up on the screen. I've talked about it before. So, looking for biases means we have to look for biases, ideas, opinions that systematically favor one arm or another of a study. Now, this can be selection bias. You all know that a selection bias in the literature comes from the fact that you select the patients in such a way that they go in one direction or another. It can be performance bias, the way the intervention, surgical intervention, endoscopic intervention, the drug that you give is given, is taken, is administered. It can be detection bias. Detection biases are the way you look for the result, how you detect whether the therapeutic decision works or not, or attrition bias. Now, attrition bias is something also that is very important in evidence-based medicine that I'll just touch on now. When you do a study, when I say we do a study, this is how we look at the literature, and we look and to see how many patients were followed and analyzed at the end. Those that are lost, attrition. take away from the credibility of the final analysis. Let me just give you an example. If you do a hernia operation, you do a hernia operation because the patient has a bulge, inguinal hernia, even sometimes not very symptomatic. But that bulge is what he sees, what the patient sees. The operation takes place. Most, if not 100% of the time, the bulge is taken away unless there's a recurrence immediately because of sutures that break. The patient wakes up, the bulge is gone. For the patient, the operation is a success. He's followed 5, 10, 20 weeks, half a year, a year. He's doing well, he doesn't come back. The surgeon who did the operation, at the time he saw him for the last time, there was no bulge. He was cured. However, at 2 years, when the surgeon wants to really see what's happening at 2 years after surgery, he asked all his patients to come back so that he can examine them and see if they have a recurrence or not. Many people don't want to come back. Why? Well, first of all, they're okay. They think they're okay. The bulge is gone. Sometimes the abdomen is so big they can't even see they're beyond their abdomen, but still they don't feel that there's a problem, so they don't want to go back. Other people have the bulge and they went to see somebody else. They were not happy with the first surgeon, so they say, I'm not going to come back. Other people say, well, of course, people can pass away or move away. The outcome can also be determined by a questionnaire. The surgeon calls, are you okay? The patient says, yes, I'm fine. Even if he's not fine, he just doesn't want to say he's not fine. So we get to a point where a certain percentage of the participants of the study are lost to follow-up or censored, as I said yesterday. In other words, they leave the study for one reason or another. They die, move away, or they're not heard of. And if the percentage of patients that are lost to follow-up or censored is large, and the results are only tabulated on those patients that are not lost to follow-up, we have an enormous bias, because only the patients that are happy or that thought that they were cured or that the surgeon thought were cured are studied. So this is just an example of how biases can systematically favor one arm or another of a treatment. The other idea behind critical appraisal is to make sure that the equipoise clause that I talked about yesterday was applied correctly. In other words, there was no bias in the caretaker's minds that because this patient had this operation, he should have better care because this is the operation that works best. So let's go through a paper, and then in the half hour or so that's left, we're going to look at a paper and see what you come up with. The questions that we have to ask when we read a paper are, in critical appraisal, 1, in the introduction, why was the study done? And what are the aims? Make sure that the study was done because there's a real question. And it's not just based on what we called efficacy. We saw that it worked in a case or in a case series. And they said, the belief is that it works before it's proven to be effective. The efficiency or the efficacy has been shown, but not the effectiveness. Are the aims of the study clearly stated? In other words, how does the investigator, what does analysis? In the methods section, you have to look at several other questions. 4 that are given here. Are the number of patients sufficient? In a randomized clinical trial, this leads us to the idea of a power calculation, which I touched on yesterday. In order to have an adequate number of patients in the denominator, in order to essentially eliminate the type 2 error. As I said before, and I told you the citation, lack of evidence for a treatment effect is not the same as it does not work. It's not evidence that it does not work. It's just that you are unable to show that it worked. You were unable to find a statistically significant difference. We speak at that time of an underpowered study. Is the method of measurement something that's been validated and reliable? You have to realize that most hospital records are not created with research in mind. The measurements that you find in a patient file that has not been elaborated with the idea of doing research has too many items that are not relevant to research. And because they are done by human beings, there is missing data. This has to be set up prospectively and very strictly for research. So when we critically appraise the methods of a paper, we have to see how the hospital records were created and how much information is there and how much information is missing. Are the outcomes clinically relevant? In other words, what was the endpoint? What was the criteria for the evaluation of a successful operation or a successful drug treatment or a successful way of taking care of the patient in general. Surrogates may be important sometimes, but they are not always valid. For instance, saying that heart failure can be treated once the patient's blood pressure comes back to normal is a surrogate endpoint for treating heart failure. Blood pressure is only one of the elements of heart failure, one of the parameters that have to be taken into consideration. But if you just base your endpoint, your criteria of success on hypertension, this is called a surrogate endpoint, and it may not be enough to determine that things work. Next are the outcomes, are the statistical approaches sensible? Sensible in the word, they make sense. It may not be necessary to do an extraordinarily complex statistical analysis to say that A is better than B. Or, and we'll talk about this in a few minutes, it may be that the overall result of a study is not statistically significantly obvious, but when we look for some subgroup, there may be some difference that looks like it works. This is called data dredging. Dredging means dredging a river for a body or something like that. We look for something until we find it. And when we find it, we say, oh, this is great. This is one of the faults that we have in statistical approaches. The results, are they properly described? Is there no bias in the selection of the groups? Otherwise, can we generalize the outcome, the results? Do all the numbers add up? We talked about that yesterday. Were the statistical tests correct? Were they properly presented? What was the main finding? And was it planned beforehand, or was it just found? If it were just found, it might be a spurious result. In other words, just by chance. And critical appraisal of the discussion, what we're coming to now, can the results be considered against the background, the results of this study, of your study, or of the study that you're appraising? Can they be considered as fair in view of the background of what has been published beforehand? What are the implications for the use I want to make of this study in my daily practice or in my paper? I'm not going to talk about the last one, which has something to do with the technique. Okay, I'm going to stop the talk at this point, and I hope I can come up with, do you see the paper here? Can you see a paper where it's written introduction? Hello?
We can still see the slides.
You can still see the slides. You don't see the paper.
No, unfortunately, we see a slide that says critical appraisal of discussion.
Okay, well, I have to stop here. Okay. Now, can you see the paper introduction?
No, we just see your camera.
Okay, then I have to go back here. I understand.
Yes, we can see the paper right now.
Okay, good. So here we have a paper that is treating postoperative pancreatic fistula, which we will call POP, abbreviated with the POPF. So the introduction is as follows. I want you to read that. I'm going to let you read, and then I'll make some comments. Read down to table 1, okay? I'm going to move up a bit. Now you can read the paragraph that starts with hemopatch and the goal of this study. Okay, any comments on this introduction?
We have a reply in the chat. One of the listeners says, is it an ad for Hammerpatch?
Aha, good remark. We'll take a closer look at that. In other words, was the study sponsored by Baxter? Is that what you're asking? Who made that comment?
It was a listener named Kira, and Kira said yes. Her point was maybe Baxter did sponsor the study. Oh, yeah. She was asking about it.
Nothing is mentioned for the time being, but this may be one of the major biases of a study, that this was not the case. Sponsored, yes, in the sense that they gave the hemopatch to the surgeons who wanted to participate in the study. Yes, in the sense that patients were included in the study only when they had the hemopatch for free. However, there was a clause that's not obvious in the introduction that said that Baxter would not intervene in the interpretation of results in the publication and they would not give money to anybody in particular for using their product or not. And this was stated elsewhere. What I want you to...
So I'm
Yes.
sorry,
Yes.
Professor, but we have one comment from one of the listeners. So the listener said that early feeding is not practiced due to pharmacological reasons and not because of surgical reasons. But of course, it remains to be seen what we understand as early feeding. I would like to say, says the listener, that evidence-based medicine has its limitations because evidence-based medicine looks at an issue from a very narrow, a very specific point of view. And I think, says the listener, that clinical thinking should be a little bit broader than that.
As I said, evidence-based medicine is a result of the critical appraisal of literature, but also combined with experience. That's for sure. However, and we're going to look at that now, when something has been shown in a methodologically sound way, that means that perhaps what was practiced in the past, in other words, not giving patients feeding early, was just a measure of efficacy and not of effectiveness. That's the message I'm trying to get across. Well, I hope I can make the point a little bit later on. I understand the argument. I understand also that people are very reluctant at the idea of evidence-based medicine. But I'm out here to show you what critical appraisal is, and you cannot appraise the literature just by saying, oh, this is what I do, so this must be right. I'm not trying to say that that everything that everybody else does is wrong. Believe me. I'm just trying to say how you base your judgment. Okay, I hope I'm making that point. Okay, so does anybody who believes that this introduction is okay? Do we have the first idea in the first paragraph that postoperative fistula is a major problem after surgery? Morbidity, possible cause of delayed chemotherapy, and it costs a lot of money. A lot of procedures have been proposed to try to reduce the prevalence and the severity. 2 recent meta-analyses have highlighted the idea of covering the stump after distal pancreatectomy, even though a consensus conference said that there's no lack of evidence that any one technique or alone or combined worked. There were before this study 5 randomized trials that looked at non-autologous patches, in other words, not biological material, with divergent outcomes. Some worked, some did not work. Hemopatch is something that has never been done in this setting in a randomized trial. One study said that it worked after pancreatoduodenectomy, the other one after distal pancreatectomy. But these are just observational studies. One was even a historical comparison. So the goal of this study was to evaluate the efficacy before we work on the effectiveness of hemopatch affixed to the pancreatic stump preventing type B and C pancreatic fistula, in other words, clinically relevant pancreatic fistula. So here we have the methods. You don't have to read the patients. It's not really that important. The operation could be performed, I'm going to summarize, either through laparotomy or laparoscopy, without or with splenectomy, or preservation of the gastric vessels. The closure of the pancreatic shunt was left to the choice of the surgeon. It was not part of the randomization. The technique of the hemopatch was standardized. Suction and drains, were mandatory, even though there is no proof that drains have a role, but it was for the study protocol. We had to standardize this because otherwise the study would have been criticized as saying that you cannot detect the pancreatic fistula without it, but that's just something that's a little bit debatable. The outcome was clinically relevant POPF, according to a definition that's out there in the literature. And then the other criteria were measured by safety was the number of patients with one or more complications. Tolerance was the adverse event rate, and severity of complications was according to a standardized classification that everybody knows that we mentioned yesterday. The randomization, I'm not going to dwell on that as much as not more than just to say that we calculated, the power calculation was, the type 1 error was 0.05, the type 2 error was 10%. In other words, 1 minus 10% is 90%, which is called the power. It was calculated that we needed 322 patients to reduce to half the pass, to half. In other words, go from 30% to 15%. To compensate for dropouts, we sought, our goal was 360 patients. Now, these 322 patients in the power calculation would be the minimum in order to eliminate the type 2 error. In other words, have enough patients so that if we did not find a difference, that we could eliminate the error of saying that there is no difference, but in fact there is one. There was an intermediate analysis to see if we can continue the study. And so the limit of statistical significance at that point is halved. Instead of the 0.05, it was 0.025. The clinical significance was calculated by the 1 over the absolute risk reduction, what we talked about yesterday, the number needed to treat to avoid one fistula. The patient was double-blind. The study was double-blinded. The initial study was okay. And then the initiator was the study was the European Society for Trauma. And we had the ethical approval and the study was registered. Okay, now let me also point out the results because we're running a little bit late on time. Patient enrollment, 3 years. 631 patients consecutive were seen during the study period. Effectively, 360 were randomized. However, there were many randomization errors. In other words, the principle of only doing the randomization once you were sure that the operation can be performed. If you remember yesterday, we talked about that, was violated in such a way that only 328 patients remained available for analysis at that point. But then there were patients that were lost to follow-up, patients that were withdrawn for different reasons. They didn't want to complete the study. And we ended up with only 315. So what does that mean? We had a minimum necessary, which was 322, but we ended up with 155 in one group and 160 in the other group. In other words, 315. What's your comments here? I don't see any comments. We were supposed to include at least 322, but we ended up with 315. What is that called? We talked about that just a few minutes ago. No one wants to make a dive. Okay. Are you still listening to me? Can you hear me? Yes? No?
Yes, we can hear you.
Okay. So what is that called? That's called an underpowered study. Even exactly. Mikhail wrote it. Underpowered study. Not very much, but still underpowered. Even if it's one patient less, it's still called underpowered. Okay, let's go on from here. Reading the operative details, approximately half were done by laparotomy. There were some done by robotic surgery. There were some conversions and so forth. So at the end, nearly 2/3 were done by laparotomy. Overall, the pancreatic fistula rate was 27.8 when nothing was done in particular, compared to 23.4 when hemopatch was put on the pancreatic stump. The difference was not statistically significant. During laparotomy, the rate, if you only took the patients undergoing laparotomy, the difference was 20% in the standard group, 11.5 in the hemopatch group, still not statistically significant, but 0.075 is called a tendency. Going back to other subgroups, we looked at the rate, whether the pancreatic stump was closed with staples or hand sewn. In the stapled group, 180 patients altogether, the rate was 21.1 in the standard group, 21.1, exactly the same in the stapled group, with or without, or with, whatever, because it's the same hemopatch. Of the hand-sewn group, going down a little bit further, we had 26.2 in the standard group and 10% in the patients with hemopatch. And this came out to a P of 0.014, much less than 0.025. However, this is subgroup analysis. Okay, so theoretically, you have to do a very specific test to see if there is any interaction. It's called interaction. In other words, the fact that there was a combined effect of hand-sewn and hemopatch gave a statistically significant result as compared to not being hand-sewn and not with the hemopatch. We'll talk about that in a few minutes. The number needed to treat was 6. I'm not going to talk about the main pancreatic duct closure, which is very similar to that. The number needed to treat was 6. In other words, you'd have to treat 6 patients with the hemopatch to avoid 1 pancreatic fistula. That's not so bad. Depends how expensive the hemopatch is, of course. But we know the cost of a pancreatic fistula is very high. Okay, I'm not going to talk about safety. I'm not going to talk about tolerance. There was no problem with safety. There was no problem with tolerance in this study. There was a volume, there was a center effect, but that's not going to affect what we're trying to say. I want now, in the few minutes that comes, I want you to give me the main points of what the discussion should contain. The first paragraph is going to be that this is a randomized controlled trial. The patients, the number of complications, one or more complications, which I did not talk about, with 34.8% in the standard group, 24.4% in the hemopatch group, just under 0.05. However, because of the intermediate analysis, we do not consider this statistically significant because of the cutoff value of 0.25. The stump closure, as I said before, was 0.014, which is under the 0.25 rate. The NNT was 6. And that's it. That's the first paragraph. Now, what would you put into the discussion? What ideas have we brought up in the introduction that would be relevant to be in favor or against the use of hemopatch in distal pancreatectomy? What arguments can we bring up about the methodology? What arguments can we bring up about the possible patient selection or biases? The literature is very poor, as I said. There are no other controlled or at least randomized trials out there. Just 2 papers that said it worked. Observational studies. What can we deduct from the fact that if it works better in hand-sewn than stapled, is there something that strikes your mind as strange or as possible? No one's writing anything. Here we go. Okay, I have a comment saying that the placing the hemo patch is technically, it depends on the approach, exactly. We'll talk about that. That's very good. Good remark. The manual technique is crucial because of the fact that it's more difficult to put the hemo patch on through laparoscopy. And effectively, this is something that should be discussed. Yes, very good remark. What else can we discuss? What else should we put into the discussion? And that remark is going to bring out in the literature that many, if not many, more than 3/4, I don't remember exactly the number, but I'll show it to you in a while. Even though minimal invasive or laparoscopy is used widely for many operations, still today, most, and I'll give you the number, the exact number, patients are still operated on by laparoscopy, by laparotomy. So that if this technique is dependent on the manual aspect of the surgery, it might be something that's interesting. Anybody else have any other comments about that aspect? Or another aspect? Okay, time is running, so I'm going to run through things. So the second paragraph was on the costs. And the argument that was brought up mainly is the fact that a pancreatic fistula costs an awful lot of money, so that if we could calculate the cost of the patch as compared to the cost of a pancreatic fistula, knowing that for every 6 to 7 pancreatectomies, we would avoid 1 fistula, that's the number needed to treat, there would be a savings of somewhere between 10,000, a little over 10,000 US dollars. But this is just calculated from the literature. However, the duration of hospital stay, even though it was shorter, was not statistically significant. So this does not seem to be a major argument. Then there was a criticism of how it worked. Why does it work in hand sewn and not in the stapled? That's just theory. There's no evidence that anything could be determined by that. And then the argument that was brought up exactly about the fact that maybe because it's more difficult to perform through laparoscopy, this may be one of the biases that explains why the technique works better during open surgery, but it may also be, and that has to be determined by what we call interaction analysis, that the combined effect is something that has its value. That has to be determined by another study. Criticism of the fact that drains were mandatory because of the protocol, and it may have influenced the outcome because some people believe that drains are not necessary or they are even detrimental. However, read this sentence here. Although it may be argued that this could have influenced the outcome, it is likely that drainage was mandatory in both groups, the eventual positive and negative effect would have been the same in each arm. The randomization process has one quality that we have not talked about yet, that I'm going to talk about now. And this quality is that it takes care of selection bias by randomization of all the factors that we can think about, but theoretically also all the factors that we don't think about. So here we're talking about drainage, whether drainage can influence the outcome or not. But because of the effect of randomization, we can make the supposition that this was not a bias in one direction or another. Something else that comes up out of the study is those patients that were lost to follow-up. We could not actually come up with 315 patients. Follow-up for 315 patients was not recorded. We were down to about less than 300. And it was impossible to have the records for 11 patients at the 30-day visit, which was one of the protocol criteria. So the investigators went to different hospitals to make sure that they had records that their patients, even though they were not seen for the study, news about the patients was obtainable, and they were able to be included into the study, even though they did not fulfill the 30-day requirement. This is something that adds something to the discussion. Next, the weaknesses and the strengths. One of the major weaknesses, of course, is the high dropout rate, which only left 315 patients. In other words, the final sample size does not allow to come to any conclusion as to the efficacy with respect to the overall clinically relevant BC pancreatic fistula rate. However, we know that underpowered studies can be something that's used for meta-analyses later on. So they have to be reported. We cannot come to a conclusion about the efficacy of the study in this particular publication, but this publication can be added to other publications in what we call meta-analyses. And so this information is important to publish. Another weakness is the fact that the thickness of the pancreas was not measured at the staple line. It's obvious for those of you who are surgeons that a thick pancreas is more difficult to staple than through hand sewn. So this might have been a bias that could have influenced. However, once again, this is an unknown factor that should have been taken care of by the randomization. So we made the supposition that it did not influence the overall outcome. Another criticism is that the power calculation was based on a review of the literature and not a pilot study. Now, what does that mean? In the study, the power calculation was based on a reduction of the pancreatic fistula rate from 30% to 15%, based on previous studies on a different type of patch, which was a Tacocil. And there was no pilot study specifically for Hemopatch. This might be criticized or criticizable, but the justification is the fact that this is what we had. We couldn't invent something new. This is it. Last, there's a paragraph on the value of the NNT. The overall NNT was nearly 15, obviously too high to be able to compensate for the cost of the patch. You cannot say that you're going to give the patient to everybody to avoid one fistula for every 15 patients. However, in the hands-on group, it was much lower, 6 to 7. It becomes something that might be considered cost-effective. And then the conclusion. Underpowered, unable to show any statistically significant difference. The clinical impact, that there were fewer patients, even though it did not reach the 0.025. Fewer patients had one or more postoperative complications. The fact that the complications were essentially in the minor Clavien-Dindo classification is one of the weaknesses. It's not a major problem in clinical practice. The fact that in the hands-on group there was a difference, okay, but no causality can be inferred because this is a subgroup analysis. And that subgroup analysis has to be confirmed by what I said, interaction analysis. Okay. Anybody have any other comments about the discussion? We've run over a little bit over time, but that's not a major problem. I see a comment, no information on the techniques like suturing. Yes, there is information about the pancreatic duct suturing. I didn't dwell on that. The results were very, very similar to the hands-on versus the stapled because it goes together. Yes, and it was included in the discussion as well. I didn't dwell on it here. It's over here. Any other arguments or comments about the discussion? Okay, so let me summarize what critical appraisal, the title of this talk in the original program was, and how this influences how you make your discussion. The study found that there was overall, first of all, the main point, the study was underpowered. Even though there was 315, it should have been at least 322. The discussion has to state very clearly, this study was underpowered, so we cannot come to any formal conclusions. Second point was that the cost effectiveness, this was one of the goals related to the number needed to treat. But its own overall 15, it's not very cost effective. However, in one of the subgroups, 7, it starts to be something that's interesting. Third, why it works, but there might be some influencing of the thickness of the pancreas. There might be some influence of the way it was done. There might be some influence of the approach. So a discussion on why it worked, or it worked better in the laparoscopy, in the laparotomy group. Maybe it's easier to put onto the pancreatic stump in laparotomy, or more difficult to do in the laparoscopy. The fact that there was a volume effect, but when we looked at the details of the performance in all the other hospitals, there was no overall effect. I'll talk about the center effect in just a few minutes because that's important. The fact that one of the weaknesses was that drains were mandatory, but as mandatory, or the suture of the pancreatic stump were also sort of equally distributed into the two groups because of the randomization, they theoretically should not have influenced the overall outcome. And the fact that we were able to recuperate some patients for the 30-day visit requirement is also something that was discussed. So you see the main points in the discussion are our results as they compare to the literature and an explanation why they can be overcome or they are a weakness of the study and leads to the fact that we cannot come to a formal conclusion. Okay, is that sufficiently clear that you know exactly, or not exactly, but at least have an idea of how to come to a good discussion in a paper? We'll look at two papers this afternoon and see how the discussion. Okay, I see another comment that it would be a good idea to conduct a regression analysis to identify factors that influence the risk factor. Absolutely, that's one thing that remains to be done. Regression analysis to identify the factors that influence the risk of fistula. And I think the study is already underway. Any other comments?
Before we start, we've got one question from the listener, and
Okay.
I asked the interpreter to translate it to you. Okay.
Mm-hmm.
The question about randomization and all kind of separation of patients in clinical trials.
Okay, I would like to ask about the time of randomization, yes. And the types of experiments with respect to different separation of patients, double blind. Double blind is not.
Some literature on randomization, how to randomize, what types of randomization exists.
Okay. I do have some slides on that, but I'll just explain, I'll try to explain. True randomization today is made by a computer program, which most of them are free of charge. And the idea is that there has to be an independent organization that does that. There are commercial aspects of, not commercial, but let's say organizations that are out there to help you with the randomization process. In other words, the best way is for a independent office, for instance, it might be Medex or some other company in Russia that does the actual randomization. And when people are participating in the study and they want to randomize a patient, they call or they hook up to the office that's doing the randomization so that there's no possible influence there. They say they have a patient to randomize. The randomization process is done in the other office, and then the answer goes back to the investigator, and he knows how to do it. But it's done by a computer program that ensures random selection. that there's no bias in, as long as the patients are included, excuse me, as long as the patients are included in a consecutive manner. So this is the ideal way. There are other processes that are done where you have envelope systems. Envelope systems work fairly well. The only problem is with the envelope system is that sometimes the envelopes get mixed up. And if there is a small amount of patients in the study, this may bias the results by the fact that there's more patients that are randomized to one group in a consecutive manner. There are other less effective ways of randomization that I don't think we should talk about. The two major ones I've talked about, the envelope system and the computer system. So that's the best way to do the randomization. The double-blind method is something that is very important in drug trials. That's a little bit more difficult in surgical trials because obviously the surgeon cannot be blinded to the treatment arm. However, what's important is that the assessor be blinded to what treatment was performed. And this is very often possible in surgical trials. The essential point, once again, is that there's an independent organization that takes care of organizing the assessment. The patient, as you saw in the study that we talked about, should be blinded to the treatment as well. However, there should be a clause that after the date of investigation, in this pancreatic study, for instance, it was 30 days. If the patient wanted to know which group he had been allotted to, or she had been allotted to, it was possible to reveal. This is something that's ethically required by most trials. So the patient should be blinded, the assessor should be blinded, and theoretically, in trials where outside of surgery, the effector, the caretaker, should be blinded also to what treatment is being allotted to the patients. Triple blinding. I hope this answers the question. I think it was Nastya that asked the question. Is that it? Nastya, is that okay? Have you the information that you wanted?
Yes, Professor. Thank you very much. I suppose, yes, that was the full answer to the question. Thank you.
Okay, that's Alina speaking. Is this Alina speaking or is this Nastya speaking?
I'm Anastasia, the organizer of this meeting. Anastasia.
Ah, okay. Okay,
Thank you very much. Thank you.
Okay, thank you. Okay, I'm going to, I hope, be able to connect this time. I have to go back to where I was. Do you see my slides?
Yes.
Still the same mistake, or is it full screen?
Yes, it's full screen now.
Ah, okay, good. I don't know what I did.
Thank you.
Okay, so I'm going to talk about tips and tricks and tips to shorten the paper, preparing the final and the final touches. Excuse me. And then a short talk on how to select the right journal, and a short talk also on what a cover letter should include. The final touches are something that you have to consider, and it's a good idea to talk about that in the way that you finish writing your manuscript, or at least you think you so. And what should you do now? Well, there are different theories out there. It's very rare, if not exceptional, that once you think you have finished your paper, that paper is ready for publication. I personally, what I do personally and what I recommend is that when I finish a paper, I put it away. I do something else. There are exceptions, of course. The Bronte sisters used to write their novels, Jane Eyre, Wuthering Heights, The Tenets of Wilfred Hall. They sent them in directly to the publishing house and they were accepted like that. We're not the Bronte sisters. We need to pause and reflect. Usually you are, as we saw yesterday with Alexander. Did you hear Alexander? Are you listening? Alexander there? Alexander, are you listening?
Yes, Alexandra is with us.
He's not there?
She's here.
Okay. I'm waiting for your abstract. I told you to write me an abstract. Are you going to send it to me? Alexander? No answer?
Александра, вы можете говорить голосом. Professor, here is the mistake. Yesterday was Alexander, Mr.
Yes.
Alexander. Yes, he's not with us. No.
Oh, he's not with us today. Okay.
Yes, maybe later. Mm-hmm.
Not a problem. No problem. So let's go back to our talk. As we saw yesterday with Alexander's paper, you as an author are too confident. You think your paper is great. You think your paper is accurate. You think your paper is readable because you, in fact, you're intoxicated. You've lived with the paper for as long as it has taken to write it. You've revised it once, twice, 3 times, 5 times, 10 times. And what you know may be so evident to you, but not to the naive reader. So these are the reasons why you should take a break and do something else. Think about something else. Look at this. Okay. Pause and reflect. Try to get somebody who's not involved in that paper to read. The best idea is the senior physician of your team, who usually has not or little participated in the study. In any case, he has to be involved. But you also might want to get an outside reader. Don't choose your mate, might be prejudiced, but maybe a paramedic, maybe a nurse, somebody who's familiar with medicine, but is not involved directly in the study. Go back into the literature and see what the other papers had to say as a global aspect. You have analyzed those papers already, but then look at them in a global aspect. I always go back to the start after that break. I put my manuscript here on one side of my desk. On my screen, I put the instructions for authors. I read them again. I don't go through them in detail, but I know them. And I just check one by one that I have abided to the instructions for authors. I make sure that there's no problems with numerals at the start of a sentence. I check all the abbreviations, the acronyms. I make sure that they are correctly labeled. I check the spelling. I check the style. Now, the spelling, you all are aware of the fact that with Word, you have a spell checker, automatic. You can use it as you write, or you can use it at the end. Please make use of it. And make use of it in the correct way. Writing in the English literature, as we heard yesterday, can be a problem for many reasons, but one particular detail that is very important to remember is to make sure that you do not mix English or British English with American English. If you're writing to a British-based journal, it would be very well appreciated that you use the British spelling for certain words. If you are writing to an American-based journal, it would be more appropriate to use the American spelling. And in the spell checker of Word, you have those two options. It's very important, once you choose one or the other, not to mix them up. Now, I say it would be more appropriate, but it's not mandatory that you do this. However, it might be something that could influence the peer reviewer. Once again, as we saw yesterday, the peer reviewers are not always native English-speaking people. So it may not be as important as I'm trying to point out here, but I try to do this as much as possible. Make sure that all your last-minute changes, the last time that you revised your paper, are consistent. And if this paper had already been rejected and revised, that the submission to the second journal should be consistent with the style of the second journal as compared to the first. Make sure that the changes have been made. Sorry, just okay. The final check, of course, can be revised in-house, but it may be annoying to the peer reviewers. And it may be considered that the author is a little sloppy, lax, or even discourteous. Just some other details. Remember, I talked about descriptive versus declarative. Make sure that you use the right verb. Make sure you make the reader understand that you are inferring or not inferring any causality. Make sure that you use correctly the words that no statistical significant difference was found or detected, and not saying that there was no difference or the results were equivalent, the results were similar. Seeing it with new eyes opens your ears to listening to something. Print it out in paper as opposed to the screen. Read it out loud. This is especially important in the beginning of your career. It's a way of re-seeing the paper or rehearing what's inside, rereading what's inside with new eyes, new ears. Make sure that the order of the figures and tables are correct, that they are cited before they're seen, and that they're cited in the correct order. Numerical order, 1, 2, 3. Make sure that they're in agreement. Make sure that the additions add up. I don't know if we'll have time, but we'll talk maybe about the references a little bit. Make sure that the order of the references is complete. Make sure that the referencing system is correct. Once again, the editing house can take care of that. But it's better to check yourself. Yesterday, we talked about the guidelines. And I talked about the Equator site. Here you see it now. And in the middle, you can see the different guidelines for different types of studies. We saw it also yesterday when Professor Efanoff gave his talk. Go to Equator Network.org, take a look at the site, and go into the type of study that you're proposing, and go and read the guidelines. Now, most journals require that you fill in a checklist that's furnished with the strobe, with the consort, with the prisma, with the starred, that you have to fill in when you submit your paper. So you have to be familiar with this. Yes. Okay, I'm going to go a little bit further. If your trial has not been registered yet, remember that obviously for clinical randomized trials, this is mandatory. But even a cohort study or a case control study would gain in credibility if it were registered. Once you set up your protocol, register your study. There are several sites that it can be done. I've only cited clinicaltrials.gov. I'm sure that there's one in Russia. I haven't put it down directly, but there are many registries that have been approved by the International Committee on Medical Journal Editors. Choose any one you want. You can choose the Russian one by, I'm sure. And then this registration number, and there's an identification number that will be published. It's called an identifier, the IOI, and it is published with the paper. Now, why is it important to register? Anybody have an idea? Why should we register? Obviously, it's mandatory, or the journal may require it. Anybody have an idea or want to make a comment of why they think that registering a study is something important?
There are some answers in the chat.
Okay.
In English.
Okay, protocol. What do you mean by protocol? What do you mean, Kira, by protocol? I'm waiting for the translation.
Design of the study, the order of the study. I'm reading from Kira. Design of the trial.
Yes.
Design of the trial and the order of the trial.
Yes.
I meant the order. The order the trial is conducted.
Okay. Yes, this is something that's important. I see another comment saying that the reliability of the design is something that's important. Yes, of course. This is a way of checking that before the study is published, that everything is okay. But there are other reasons. One of the other reasons is that you can go into the registry and see if somebody else has not done the study on the same topic. So you know what's going, and that's not been published yet. So you might want to contact him to see where he is and see how things are going. A lot of jealousy, of course, between competing teams, but this is a possibility. It might be that a study was registered 4 years ago, but was never published. You might want to ask why the study was not published. It might be also that if you register the study, you can claim that you were the first. Several reasons why you should register. And as Larissa also has pointed out, there's ethical aspects to it as well, because of what I just said, being the first or being the original, and also being complete when you do your critical appraisal of the literature and you discussed. Now, this is a slide just to show you that there are several, in spite of what I've just said, there are people that do not abide to the rules all the time. But let's go a little bit further. Once you have finished your paper, you want to send it to all the co-authors in the, let me just take this thing off. Yes. I can't get it off the screen. You don't see the discussion on the screen. You see the full slide, right?
Yes.
Okay. So the paper has to be sent to all co-authors. They might be able to make some final adjustments, some final corrections, even sometimes some new ideas that you didn't see before. It's also required by what we call the Vancouver requirements. Now, I'm going to talk about those requirements in a few minutes. And this is something that we can do today very easily through a Zoom or a Teams-based format, like we're doing the conference today. Authorship is something very important. Authorship is something that is an essential component of academic medicine today. It is a means of bestowing credit for the intellectual achievement of publications. It is a means of accounting for what the contents of the publications are. And it may have a direct effect on whether you get a job, whether you get an increase in salary, whether you get funding, how you deal with your grants and how well you make a grant application, your promotion, your tenure, or other honors. And it is absolutely necessary to abide to the ICMGE requirements. I'm going to talk a little bit about what we call honorary authorship or guest authorship, sometimes even coercive authorship, arguments that arise because of the order of the authorship, authors that are left out, and ghost authorship, and the fact that the number of co-authors increases over time as the paper becomes publishable. Let me insist on some of those aspects. Inappropriate authorship is something we have to deal with when we're young. This comes from the fact that many our bosses don't, let's say, they encourage the publication, they want the publication, but they do not participate in the publication. They want their name there. And they even sometimes even are coercive in saying, I want this other person's name there, who doesn't do anything with the paper either. This is not ethically correct. And it's a problem that even though we have to deal with daily, and it is a problem of hierarchy sometimes, you have to absolutely be adamant in your demand. And the best way of avoiding problems with who is going to be one of the authors, who is going to be credited for doing whatever, is to get this information officially at the start of the paper. Talk to your supervisor, have an honest talk with them, and make sure that this is not a problem. It may seem trivial, but believe me, it is more and more of a problem, and I'll tell you why in a few minutes. Yes, one survey, fairly recent survey, 2018, said that somewhere around a half of the individuals that are credited as authors or co-authors should not have been such. About half of the first authors experienced some sort of unethical pressure regarding the authorship order. In other words, everybody knows that when a paper is cited, the first, second, and third authors always get cited. The last, never. Sometimes the fourth, sometimes the fifth. But people like to see their name. So they want to be moved up, even though they don't qualify for that. Another aspect is the conflict of interest, as we talked about before, but I'll not touch about that today. One of the major problems is how many authors should you be including in your paper? This has to be decided from the beginning. And you have to make sure that the boss agrees to the fact that no names will be added afterwards. I know this is sometimes a difficult situation for you as a young surgeon or a young physician, especially when you're working with a boss that's very powerful and very coercive. But it has to be, you have to try. What about the statisticians? Theoretically, they can be an author if they're not paid, but only if they abide to the Vancouver authorship requirements that I'm going to talk about in 2 or 3 slides. Otherwise, you cite them in the acknowledgement. Authors that have their name in a publication have to abide to specific requirements that have been put down by the ICMGE. And I'm going to take some time to look at these with you. There are 4 criteria, 4 requirements. And to be an author, you have to abide to all 4, not just one. Now, this means For one, contributions to the conception or the design, or the acquisition of data, the analysis of data, or the interpretation of data. That's one. But that's not enough. You also, even if you just had the idea, you have to participate in the drafting or the revision. 2, now 3, everybody has to agree, and some of the submission processes will require that every single author agrees. Once you submit the paper, you have to submit the corresponding author has to submit the email of all the authors, and they get an email back from the editor saying, your paper has been submitted with your name on it. Do you agree? And you have to send back an answer, yes or no. And last but not least, you have to be accountable for all the aspects of the work, ensuring the accuracy or the integrity. Now, this is an ethical issue which is absolutely essential. And I think I'm going to show you a slide in a few minutes of something that happened, which is disastrous. So here is an example of what can be published. Contributed 1, 2, 3, 4. Everybody has given their approval. Here is another example. Here's another example. Only one person. Okay. Especially agreeing to being accountable. And why is this important? A couple of years ago, in the 1980s or 1990s, I don't exactly remember when, a certain cruise, a Brazilian neurosurgeon working in the United States, published 3 papers about high-dose mannitol used for cranial fractures, people with the subdural hematoma or just traumatic head injuries, non-penetrating. He looked at the influence of high-dose mannitol with the endpoint of death at 6 months or disability at 6 months. And he published 3 papers, which is a little bit criticizable also, because certainly they were what we call salami slicing. They were the same patients, but that's another problem. This Cruz, once he published these papers, was immediately invited to give talks about high-dose mannitol and head injury. He became famous overnight. He was invited to meetings. He was invited to conferences. He was invited to write other papers, to do review papers. And then suddenly he committed suicide. In the United States, when you commit suicide, there's a police inquiry. They go into detail to find out if there's a drug problem, if there's a girlfriend or wife problem, if there's a financial problem or something, to determine the reasons for the suicide. And they even have the right to go to the person's home and look for evidence of something going wrong or something that might indicate why the suicide took place. And they went to Cruz's house or apartment, And what did they find? They found a letter saying that his boss at that time had asked him to do this paper. And he wrote the paper. He even included other people. Very happy to be one of the authors. However, no one actually contributed any patients. And what was found out is that Cruz actually invented entirely this study. They knew about the efficacy of high-dose mannitol, and it's still used today. It does work. It is effective. But the studies that we were talking about in the beginning, those 3 studies that are in the background there, were entirely invented. Not entirely. Some of the cases might have been true, but the papers were invented. And when they inquired, we went back to the co-authors. They said, yes, I'm a co-author, but actually, I just talked to him on the phone and never had the opportunity to check. I just agreed to it because I know he's a good guy and I like him. I know him personally and so forth and so on. Can you imagine? This ended in suicide. And because of the fact that he became famous overnight because of a falsification, he just could not live with it. And this was the reason why he committed suicide. So you see, you have to abide to the 4 requirements and assume the responsibility for the contents. There's another story that I have not been able to find on the web, but I'm sorry. I just want to relate to you of a very famous surgeon in Munich who was chief of surgery and did not follow all the research that was being done in his unit and was a little bit too eager to get papers published. And when one of the research papers was published, it turned out that once again, the research was falsified. And this guy lost his job. So take the matter seriously. Authorship is a serious affair. Now, what about the number of authors? Many journals require that a paper should not have more than 6 authors. More and more today, we see that there's more than 6. And the number of authors is increasing over time. The idea behind this is that the journals are getting a little bit more and more tolerant to the fact that they may be more than 6 authors. However, there still are journals that are very strict about the number of authors. Go to the instructions for authors. Make sure that there's no steadfast requirement. For instance, the World Journal of Surgery used to have a very strict authorship requirement. They have changed a little bit nowadays, but still, they will ask the question, have all the authors corresponded and agreed to the 4 Vancouver requirements that we talked about. I just cite a paper just for everybody to look and laugh and to see that this paper was published with 214 co-authors. Impossible today. This is no longer admitted. Okay. Group authorship is something that is a problem that we have to talk about. The indexing systems today are not well adapted to group authorship. And we have to talk about this. There is a system out today where authors can claim that they contributed equally to a publication. The first author is always the first author when the paper comes out and when it's published. However, locally in the person's unit or hospital, there may be some sort of recognition or attribution, honor, or compensation to which he can make a claim. The second author can make a claim, or the third, as you see in the Japanese. So this is why this system exists. However, in the indexing system, it will always be the first author that's the first author. So in fact, this can count for professional advancement. However, there is something that should absolutely be avoided, and that is what we call ghostwriting. Does anybody know what ghostwriting is? Who has an idea of ghostwriting? And a ghostwriter. Anybody want to make a comment? No comments? Okay, a ghostwriter is somebody who writes the paper or contributes to the writing of the paper, usually writes the paper, but can also be a contributor, but does not get his name as an author. Usually it's somebody who's paid to do so. And there are many, many sites on the web that offer these services. I'm not talking about corrections. There are also units, services, even the editing houses that offer corrections of paper. But ghostwriting is not acceptable. And I make a plea, an open plea to you, do not use ghostwriters that are available on the web, even if they look like they're certified, even if though they look like they are something that's interesting. Remember yesterday when Professor Ergenov talked about the fact that some Southeast Asian journals at one time required, and even the Romanians and the Eastern Europe Romanians required that you have an official look at the English of your paper, and he gave you an official certificate of approval that you could publish it. That is no longer required by major journals, at least. And it's a little bit different from ghostwriters. Now, ghostwriters are absolutely to be banned. Let me say why. A little bit of a story. There was an anti-cox analgesia that was put on the market several years ago called Vioxx, Vivox. And it was absolutely fantastic. It was a sensation. It was a scoop in the medical field of anti-pain painkillers. And the original paper was published in JAMA, which was a very high impact factor, very reputable journal. And then there happened to be some cardiac incidents and even heart attacks. And then one patient died. Those were, at that time, the restrictions, the requirements for the FDA approval were not as strict as they are today, but there was an inquiry. They went to the laboratory that was responsible for the publication and for the marketing. And they looked at the possible adverse events, and nothing was mentioned about cardiac or heart related complications. So they went to the first author. They asked him, "Are you aware of this?" He evaded the question. And so they had to make an official requirement, an official inquiry. And they found out, in fact, that the paper was written by a ghostwriter, somebody who did not appear as one of the authors. The affair was very serious because obviously the parents of the deceased person had brought the issue to court, and they found the ghostwriter. They asked him how he did the paper, what information he was made available to, how was the data analyzed, and all the details of what he published. And what happened? In fact, he had the data of possible cardiac events, but no one was ever able to find out who in the hierarchy above him in the pharmaceutical company said, "We'll write another paper, a second paper about those aspects. In your first paper, don't talk about it." The ghostwriter is paid for this job. He has no ethical considerations other than being paid. So he wrote the paper. He listened to the guy, said he didn't talk about the... So you see that ghostwriters are not responsible people. They're there just to make money. You cannot depend on them. If there's any clinical or ethical issues, the ghostwriter will not be able to deal with that. So don't involve them. Okay, so these are the tips and tricks to shorten your paper. Make sure that you don't get any repetitions. Make sure that you get all the figures correctly. And I've talked about some ethical issues also. Where can you publish? And how do you choose the journal where you want to publish? You can choose your journal based on several aspects. if you think that your message is very important, you may want to go to a very high impact journal. It may also be that you want to target your readership. If you're highly specialized in a very particular aspect of surgery or of medicine, you may want to publish in that highly specialized journal that deals only with or mainly with the problems that you are involved in, and you know that your readership is going to be involved in the same field. As a matter of fact, when you do go to journals like that, your introduction, for instance, can be very specific. Only 1 or 2 paragraphs are needed. It influences the way you write. If you're going to a wide readership, you may want to have a long introduction to make sure that everybody, like the paper on the pancreatic fistula, that everybody understands all the problems that are related to the topic that you're talking about. You also may base your choice of journal on what you're looking for. Are you looking for diffusion of information? Are you looking for personal advancement, either increasing your reputation or getting better or increasing your referrals? Or it may be that your goal is to audit what your results are, to make sure that you're doing things correctly in accordance to what the guidelines say and to what other people are publishing. So how do you choose that journal? You have to look at the quality of the journal and the impact factor. You have to inquire not only the journal that you read, but the journal that your other colleagues read and your seniors read. And once again, gear your choice on whether it's a generalist or a specialist journal. You might also want to just say, well, I want to send it to the journal that's most likely to publish it. Sort of not aim very high as far as the impact factor is concerned. Nowadays, you have sites on the web that help you choose your journal. Now, some of these are editor-based, like Elsevier or Springer, but also there are some little bit more, let's say, neutral aspects or sites that you can see. The second, the third, and the fourth are much more neutral. This is what the Elsevier site looks like. You get an answer within a couple of hours. It's very, 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 very quick. Let's talk about the citation indexes a little bit. The ISI, an institute that's based in Philadelphia, has a journal citation system that we're going to look at in a few slides. And you can go to the ISI website to find out a lot of information about what we're going to talk about. But I just want to concentrate a little bit on what we call citation indexes that are due to this gentleman from Philadelphia, as a matter of fact, a doctor. I don't remember his specialty, but anyhow, he was the Eugene Garfield in the 1950s in Philadelphia came up with this idea. And he came up with several types of indexes. And these citation indexes became what we know today as the impact factor. Now, the citation indexes are something that has been studied in detail by many people. This is a paper by Mike Saar a couple of years ago, who was editor-in-chief of Surgery, that looked at the impact over years of how a citation, how papers were cited according to whether it was a review article or a letter or a full paper. And you see that the full paper has a longer lifespan than the other types of papers. Now, the citation index, as I said, led to several types of indexes. One of them is the immediacy index rating, is how quick a paper is published. But I'm going to insist more on the impact factor, which is defined as the number of citations in the literature made by other journals for any items published in a specific given journal in the 2 years preceding the publication under study, divided by the total number of citable items. Now, there is a total number of articles that are cited in that same journal during that same period of time, the 2 years. So, for instance, I think I calculated this for Nature or whatever, and here's a list of, so the number of articles cited in 1 year among those published the 2 years preceding in the same journal, published by the total number of articles published by that same journal during those 2 year periods. And so here you see a list of some of the major journals out there today. And you see that you have different citations that are made here. And they come out with the impact factor and also something that is called the H index. Now, this leads me to talk about predatory journals that are out there today. Predatory journals are journals that have flourished in the last 5 to 10 years. Predatory journals are a danger to our profession. Predatory journals are pay-for-fee journals that offer their services. They offer quick publication. They offer help with writing the paper. They offer a lot of things. However, for a cost, and a lot of people that are interested in publishing quickly for personal reasons go to these journals and accept to be published. These journals, even if they say they are peer-reviewed, the peer review is not correct. Even if they say that we have checked that the contents abide to the rules, this is more than often not true. They are a very aggressive group of companies out there that are only there just for financial gain. And please be very careful before you try to publish something in what we call predatory journals. Predatory, everybody understand the word predatory? A predator is an eagle, for instance, an eagle doesn't care what animal's down there, it's food. So he's gonna go swoop down and pick up the snake or the other bird and eat it. So These are what predatory journals are about. Now, these should be distinguished from other reputable journals, which are what we call open access, which are subdivisions of reputed journals, but that you have to pay for also. And why do you have to pay for that? Well, this is something also that comes out of a recent European directive. I have a slide on that, but not in this talk. Let me see if it's here or not. No. Anyhow, I'll talk about it. It's called the Plan S. Plan S. The Plan S was set up by the European Union in 2016, 2017. And it was supposed to come into rigor beginning of 2019. And then, of course, with the COVID, everything got stopped. And whether it's going to make surface someday or not remains to be determined. The idea behind the Plan S was to provide money for research and help people with their grants. In other words, once the grant was accepted, you had the requirement of publishing that paper in an open access journal. There's obviously a conflict of interest, as far as I'm concerned, is that the journals got together and said that this would be something that would promote publication in open access. In other words, journals were losing money at the time, and they saw this as a means of increasing their financial gains, but still abiding to strict rules on publication with peer review, board of experts, recognizing the publishing standards to keep up with the other journals, and to have journals that are indexed. You saw the example yesterday of OpenBGS. OpenBGS is the same, has practically the same reputation as BGS, but it's an open access journal. Annals of Surgery has the same. Annals of Internal Medicine has the same. The only journal I know of that doesn't have an open for the time being is in New England, for instance, but I'm sure they're going to do it someday. So the requirement in the Plan S is that you publish in an open access journal. And money should be attributed to that, but it has to be transparent. There does not seem to be many legal problems there. In France, there is a system which is called the CGAPS, where for a clinical trial, the center or either multi-center or the monocenter study gets a certain amount of points. Points according to the type of study. Phase 1 and phase 2 trials get more points than a phase 3. Each point is worth a little bit more than 3,000 euros. And that can come to a considerable amount of money. For instance, a study can get it easily up to 20 to 30, sometimes 40,000 euros, and it's per year. The investigator also can get specific funding, a little bit less than the center, but all this money has to go to a traceable bank account, and the expenses have to be recorded. It's very strictly regulated. And in France, it works pretty well. Some centers have very high budgets that are responsive, that are helping the clinical research in those units, and it's something to take into consideration. But there also are other systems out there in the world. The US gives stipends for any time a paper is cited. So this also can come to a considerable amount of money for the unit that publishes. Other countries have other systems. For instance, China, which I am aware of fairly closely because I have a lot of mentees that are from China and Taiwan. The institution in those countries, in China and Taiwan, the hospital, in fact, will provide awards, money awards for publications. And in China, for instance, any paper that is published with the name of the hospital on it, of course, for the first author, in an in a journal with the impact factor over 5, will get a stipend, which can be considerable. It's related to the impact factor. The higher the impact factor, the more the money. And this can amount to 30 or 40,000 US dollars as well. And you see the list of the countries that use this most is China, the Middle East, Malaysia, Taiwan, the United Kingdom, United States, and then back to Middle East, Australia, Pakistan, India, and so forth. So a lot of countries have this system. I didn't see Russia in this system, but maybe somebody would like to make a comment about that and tell me if the system exists in Russia. Perhaps Michael, you can make a comment about that when I finish my talk here, which I have, as a matter of fact. I have another talk on a cover letter, but I'd like to hear, Michael, if you are aware of any of this. Is there a system like that in Russia?
Unfortunately, we have no such a system that encourage the scientists to publish their studies in high impact factor journals, unfortunately. But it's a good idea. We should discuss. Maybe we can change the situation.
Yes, I think this is something that's worth discussing. I think it's a very important incentive to good medical writing if it's done correctly. There has to be rules. This has to be done correctly. That's all.
Yeah. Thank you for idea.
Yeah. Can you see my slide now on the cover letter?
No.
I hope we're not going to go back to the same problem again. How do I do this? Let's go back here. Here we go. Okay. The cover letter should be this one. Okay.
Not a full screen, but it's okay.
We went back to the other system. Okay, let's go. So the rest of my talk until 12 o'clock is going to be about the cover letter. The cover letter, or this accompanying letter, is something that you might want to use, or you have to use, let's say, Well, let me try it. I just can't understand. Let me try some other system. Is this better?
Yes, it's full screen. Yeah.
Okay. Okay. Then I found out what's going on. Okay. So the cover letter can be something that you write for a first initial submission or a resubmission after you have been asked to revise your paper, or ulterior submissions after your first paper was rejected. We'll talk about rejections after lunch or after the break at 1 o'clock. It used to be something that you did very quickly, that should not be neglected whatsoever. This is something that you should take very seriously. It's a letter that's addressed to the editor and the editorial staff, not directly to the peer reviewers, but sometimes the peer reviewers do see it. So be careful that you don't say anything you should not be said in that letter. And unofficially, it's where you explain what and why you did not do exactly what you were supposed to do, or why you did not exactly adhere to the rules of the instructions to authors. So let's look at a first submission. It's basically the same for other aspects, but we'll talk about the specific aspects as we go along. You address the editor by name. Now, look into the journal, see what his name is. Don't say, dear professor or dear doctor. Put his name there. Put his name in full, his surname, of course, his family name. This is preferable to dear editor or dear sir, which are much more impersonal. And never use something very impersonal like to whom this may concern. Sorry. Try to personalize your paper and your relationship with the editor. We heard about this yesterday, and I agree 100% with Michael about trying to get into contact a little. Don't be afraid, don't be ashamed, even though these are highly reputed people, high with very, let's say, notable reputations. It's still something that you have to deal with, and the best way to deal with that is to try to personalize your relationship through the cover letter. You begin with a paragraph that gives the full name of your manuscript and all the names, the full names of all the authors. Don't leave anything out in the cover letter. You also can tell the editor that your type of manuscript is your research article or a review of the literature, a case report, a cohort study, a case control study, or whatever type of study it is. Then you give a few lines describing the rationale and why you did that study. Why you thought that piece of research was important. It's almost like a redo of your introduction. What is out there in the literature and why you felt that it was necessary to do something more. What was missing in the literature, and this was designated, your paper was designated to try to fill the gap, as I talked to you yesterday in the introduction, of something that's missing out there. Or it may be a runoff or a spin-off of something you've already done, a prior work, but give proof, send as an attachment the other paper or the other paper, proof of the other papers being published. And then spend some time with a short paragraph that explains why you think the manuscript would be good for the particular journal to which you are submitting. Why is it a good fit? Why is it appropriate for that journal? Something more than just saying of interest to the field or a novel contribution to it. You have to look perhaps into the journal's instructions or to the first page or the cover, the reverse cover page of the journal, and to find out what the journal's aims and scope are. The journal usually gives an idea of the specific interest in research and the clinical applications that they're aiming for in their readership. And if there are any specific terms or specific categories of readership or categories of topics of papers that are indicated in the journal's aims and scope, mention it in your cover letter. Try to push your journal, your paper into that journal with their own arguments. Mention that the journal has published 2 or 3 papers on this same topic, but you feel that your paper contributes a little bit more, adds something to the other papers. Don't try to diminish the importance of the other papers, but say that your paper is going to add something to the worth of the other papers published in that same journal. Once again, the journal is interested in increasing its impact factor. So if you mention that you're talking about citations and things like that, indirectly, you are indicating that you're contributing to increasing the impact factor of that journal, and the editor will appreciate that. In the letter to the editor, I think it's important to mention that none or no part of the manuscript has been published before or is under consideration for publishing in any place, excepting if it were published, for instance, not published or published and produced in a meeting, in which case you mention where it was published. There's nothing wrong with that. It will be published sometimes, as you see the citation here. But do not hide any duplicate publications, even if it's in a journal, for instance, that has been published, a paper. You may want to publish a paper in Russian, in a Russian journal, and then publish it in English. It's okay, as long as both journals accept the fact and are aware of the fact that the paper was published in a different journal in a different language. I have never seen a rejection of that. However, I have seen articles that have to be retracted because they were published in 2 different languages, and the authors did not tell the second journal that the paper was published in another journal of a different language. So get the approval before you do it. It's possible, and I see no reason why it should be rejected, as long as it's recognized, as long as it's known. Make sure that you say in the cover letter also that all authors have seen the paper, that all authors have approved the paper, and that all authors have abided to clause 1 and clause 2 of the Vancouver requirements. It's good to state it in writing in the cover letter. I also advise you to say that there's no conflict of interest, or if there are, to say so in the cover letter. I also advise you to say and look for the instructions for authors. If you have colored figures and there's a fee that's required for that in the cover letter, you can give your agreement already, saying that you're willing to meet the possible costs of a color reproduction. That's going to speed up the process. Otherwise, the journal has to write back to you saying that if we publish your figures in color, do you agree to a paying for them and so forth and so on? It's back and forth. Well, today, everything is done with emails, but still, it may delay the process of peer review and eventually the process of publication. So you want to be sure that, or you want to try at least to expedite the publishing process as much as possible. The author should make a point in this cover letter to make sure that the editor recognizes that the article is original and has not been submitted elsewhere. This is also where you explain exceptions to the instructions for authors. For instance, if you have an abstract that goes over the number of words that's admitted, you may want to say that you have 251 words and it's only 250 that are admitted. However, some of the submission processes are permissive. Now, a permissive submission, I have to explain maybe what that means. The word permissive, I'm sure you know what that means, but the electronic permissiveness is something very specific. When you submit a paper electronically, you have to copy and paste your abstract into a box, electronic box. And that box has a word counter. So if the limit is 250 words and you have 251 words, the submission process will not allow you to go to the next page. There is a permissive, what they call a permissive step. So this is me. You may have to explain that if there's not a permissive step. It may also be that your number of references go over the limit of the instructions for authors. Instead of 40, you have 41, but you have to justify that. It may be that you have some of the references that are papers that have been accepted but have not been published, and they're in press. Now, what I recommend very strongly is, if that is the case, that you provide proof to the editor, saying so in the cover letter, that you have attached proof that the paper has been accepted for publication. What is absolutely unethical is the fact that you say the paper is under publication because you sent it in, and in fact, it was rejected. So you have to provide proof that the paper has been accepted. Just send in a copy of the letter of acceptation from the journal under consideration. I've said this before, but let me say it again. You have to say in the cover letter that all the authors have contributed to the Vancouver requirements, as you see here. Otherwise, you acknowledge the other contributions. As I said before, some of the journals, like the World Journal of Surgery, will not accept more than 6 authors. If you absolutely insist on more than 6 authors, and it's in the instruction for authors, you can try to persuade the editor that it's very important that the 7th author be there, and give reasons why you believe that 7th author should be among the co-authors. If there's any copyright issues, this is where you state that also, along with the conflict of interest. This is something that you might want to, a place where you want to say that you are very adamant about the fact that figure 3 should be on this page. You can do it in the text, but you can also do it in the cover letter. It might be also a reminder to say whether you want a portrait or a landscape format for a specific table or a specific figure. The registration we've talked about, but this is something you might also want to mention in the cover letter and give the number. As I said before, that is published with the journal. Now, this is something also that in some of in the submission process, many journals today will ask you if there are any specific scientists in your field or in another field that you might want to select as a potential peer reviewer. They may also say, are there any specific persons that you do not want as a peer reviewer? If that is in the submission process, then don't worry about it in the cover letter, except that you may want to put it in the cover letter if it's not mentioned in the submission project, or give an explanation why you wanted this specific reviewer or you did not want this other reviewer. It's good to put it into the cover letter. It's as I said, it's personalizing your relationship with the editor. Something that's going to please the editors and the peer reviewers also is to send extra material, for instance, the consort checklist or the Prisma flow diagram, if it is not already required, as I said in my talk before that. Very important also in the cover letter is that the editor should have all the necessary information to contact the main author or the corresponding author, especially when the corresponding author is not the main author. And this is something that you should be indicating in the in this cover letter. Here's an example, a very brief example, but still an example. Type of report. Please enclose, please find our manuscript, an original report. An original report is a type of paper. It should be perhaps original scientific report would be more correct, but anyhow, original report is okay. Titled. The entire title. I would have put the number of authors after that. The letter goes on. The study was conducted in 2 independent institutions. It was a new attempt to make prognostic stratification, something going on. Parts of this were represented in a meeting. Most of the factors have been analyzed repeatedly in the literature and are regarded as important for patients who undergo or have undergone hepatectomy for liver metastases, such as the number, the size, and so forth and so on. However, like in the introduction, the broad application is limited value. So we focused on the histologically expressed tumor aggressiveness and found that novel parameters such as poorly differentiated clusters impacted the postoperative survival and that they were independent of conventional prognostic factors. This is the value of our particular paper, and you're highlighting the characteristics of this paper as compared to what has already been published and what is already available on the topic in the literature. Then, of course, each author participated in design and so forth and so on, as we've talked about. Paper has not been published, and so forth and so on. Don't be afraid to write 2 or 3 pages. As I said, this is personalizing your relationship with the editor. The first time you do this, it may be a little bit painful, it may be a little bit time-consuming, but believe me, the editor will remember that you did this. And electronically today, when an editor gets a paper and a cover letter that's a little bit flourished, a little bit, let's say, well done, he will immediately, if he doesn't remember the name of the author, he will immediately look up and see if other papers have been submitted to that same journal. And he'll have an idea immediately that you were somebody that's serious, somebody that took the relationship between authorship and publishing as something important to you, that you did a good job last time. The paper may have been rejected, but you still made a good cover letter and did a lot of efforts. This is something that might be a factor of acceptation and should not be neglected. If it's a resubmission, well, the cover letter, of course, is important, but it's not the same, does not have the same contents. Here, your goal is to provide the editor with assurance that your paper your paper is of special interest to the journal, and it will contribute to the reputation of the journal. And the thing to begin with is thanking the authors and the peer reviewers, the peer reviewers for indicating changes. And then you go on to comment on the queries raised by the reviewers. And what I do and what I recommend is indicated here, is I copy and paste the reviewer comments, or I make a comment like you see here. Thank you for your initial comments. As for your first question, I deal item by item. I cite. They asked the meaning of the choice of the technique was based on a mutual consented decision between surgeon and patient after adequate explanation of the advantages and disadvantages of both techniques. We explain why the choice was given to the patients in the thing. And then you say, well, we have modified the paragraph under consideration, and you copy and you paste what you did in your new edition. This letter also can be very long. Second reviewer, the same thing. Always thank you for your review. We agree or we disagree with something. Explanation of what you did. Here, this was something that I'm sure, Michael, you're going to laugh. The peer reviewer did not see that, he did not read the paper correctly. So we say very nicely, the method of specimen extraction was clearly stated in the paragraph where two techniques were described, and we just, repeat the paper to make sure that he understood that he didn't read it. And then we say we clearly indicated that all patients had the same bowel preparation and so forth and so on according to the protocol. Decided that we just, we didn't say we did add anything, we didn't change anything. We just pointed out that we did do what he did not see. So very polite. Don't attack the peer reviewer. The peer reviewer, if you attack him, he's going to refuse your paper. Review number 3. Once again, here is the explanation. Stating what is going on in that unit, stating what is specific to obese patients, and then coming up with a statement, as you see here. This was underscored in a discussion where he indicated the possible limitations and weaknesses of the study, that the modifications have been made. As I say, this can be up to 3 or 4 pages long. And then you end with a statement. I remain at your disposal to answer any queries. I hope that this manuscript will be published and so forth and so on. This is valuable for the original cover letter as well as the cover letter for the cover letter for the submission. I will talk about resubmissions tomorrow, and again, or not tomorrow, but a little bit later, and you will see that there are specific items that you have to include, what we call the red copy and so forth and so on, but I'll talk about that, as I said before, between 1 and 2 p.m. this afternoon. Just a few slides now about the electronic submission system. Just to point out that all electronic systems are mainly based on the same sort of process. You have to give your email, you have to sign in, you have to establish an account. And once you have established that account, you go to the journal, several different slides, different journals. They're basically all the same. Once you have signed in and you're recognized as somebody who's signed in, you have to say whether you're a reviewer or an author, whether it's a paper that's under publication, under submission, as a new manuscript or being published, whether it's been rejected otherwise or whatever, what type of study it is. Then you drag or you browse to your directory to find the information that's necessary. You indicate that you have a cover letter, you include the cover letter, you put it into the system. You put the abstract in, you put the mini abstract in, you put the tables in individually. You describe what the country of the first author is. Here's the section on what I talked to you about, whether you want a specific person to review or not to review your paper. And as I said before, if you do indicate anybody there, you might want to include in your cover letter a reason why you wanted or did not want a specific person to be one of the peer reviewers of your journal. Here we see the person indicated the reasons why, but you may want to elaborate, as I said before, in the cover letter. And then many journals, including, for instance, Annals of Surgery, will require that you give information about the type of the study, the conflicts of interest, and so forth and so on, whether you have filled in the consort statement guidelines. And usually these are, as you see here, drop-down menus. It takes some time, but it's not that difficult to do. Very little editing is necessary. Most of the answers are indicated in a drop-down menu. And it goes on to me, Annals of Surgery is about 3 pages long, or even more. So this is what it looks like. And then finally you get to the end of that long list and you have to agree that your paper is original. You have to agree that you are accountable for the contents, that you have contacted all the co-authors and so forth and so on. It's getting to a very lengthy process, especially in the United States, but also in the United Kingdom, for medical legal reasons. And the reasons are the papers that I cited, the medical legal background and dropouts of false information. We just can't deal with this problem otherwise today. The lawyers are out there to make money, and they're looking for flaws, and they know that the medical profession is very, let's say, predatorily susceptible to be involved in this sort of court issues, and you just have to be very careful that you do everything correctly. Going on into the review process, then you have to also give any direct information about any disclosures, any conflict of interest, as I said. Any additional comments? None. You agree that you are the author, that you are responsible for the information that's being put into the submission process. And then you go on. You have to give the title, you have to give the keywords, you have to give all the authors that are responsible. And if you make an error, this pop-up comes in and says that, oh, you're missing information, you have not suggested reviewers, the author's information is incomplete, you have to go back to that section and fill it in, otherwise these are permissive measures that will not allow you to submit your paper. So until it's all filled in as it's supposed to be, the paper will not go through. Now, there's something that's very convenient today is the ORCID system. I advise all of you to register in ORCID once you start your era of publication, because your ORCID number gives you free access to a lot of publications, first of all, and also in a submission process, you can use your ORCID number where all that civil information, your name, your prename, your first name, your family name, your affiliation, a lot of pre-required information is already recorded, and you don't have to do it again and again and again. You just give your ORCID number and everything is filled in automatically. So please register with ORCID. It's a fairly straightforward process, and it's not that difficult. It doesn't take that much time. And once that's submitted, you look for the ORCID search and so forth. Some journals will require that you fill in the consort statement, or that at least that you click on the link to make sure that you've looked at it. Once you click on the link, you're allowed to go back. Okay, the referees, okay, we've talked about that. And then some journals will summarize what you have attached online and what you want to do offline. Now, this is also what we call a double-edged razor. Most journals today will not give your paper, will not, let's say, forward your paper to a review process if you have not submitted everything. So I advise you not to say that you're going to do something offline. It will delay the process of peer review and therefore of possible acceptation. You don't want that. So make an effort to submit everything that's required online, on time, so that things can go correctly. If your submission is sent back, take care of it immediately. Usually if something is missing, you're going to get an answer immediately back from the journal saying that something's missing. Take care of it immediately. Okay, I think I've covered most of the important facts in the cover letter. Now I'm open to any comments that you might want to add. Okay, now I think Mr. Mirzaev is scheduled to give a talk on submissions. So I'm going to take the liberty of giving the microphone over to him. And then there will be a break until 1 or whatever time Mr. Mirzaev ends, I will be back. I'm going to go downstairs and then come back and listen to his talk. And then we'll break for 20 minutes, as we said yesterday, for a sandwich or a coffee. And we'll be back and talk about special aspects of writing a surgical paper, corrections and things like that.
Yes, Professor, thank you very much, so much for your report. It is, as usual, very useful, interesting, and informative. Thank you very much.
Okay.
Yes, and now I'd like to introduce the next speaker.
I'll be back in just 2 minutes, okay?
Thank you. Mirzaev Karin Badavievich, candidate of medical science, head of research laboratory of genomic predictors of adverse drug reactions of Research Institute of Molecular and Personalized Medicine of Federal State Budgetary Educational Institution of Further Professional Education.
Good afternoon, dear colleagues. My presentation is devoted to the main errors in publishing scientific articles. What can be done for the article to be expected 100%? How to communicate with students, how to choose journals, how to miss different errors at different stages. So the presentation has been made jointly by Dr. Mirzaev, Dr. Ivashenko, Dr. Fedorinov, and Dr. Suchov. Speaking about publications of scientific articles, we may show the evolution of the publication from the absence of the publication to the publication in the global science journals. We can give the example of the evolution of man from the to the thinking man, and this while the skill was developed, the evolution was taking place. The first is organization of the trial. Our trial was made with 2 groups of educational institutions, the Amosov University in the Far East and the Sakha-Yakutia hospital. So we collected the material together. And the third participant is our Academy of Continuous Medical Education. The article has been written, it is ready. I won't touch upon the process of writing. The main object is our publishing. So the article is ready. It is devoted to pharmacogenetics of anti-aggregants and pharmacodynamics of PPIs and the testing by clinically important factors with the patients with acute coronary syndrome and with the Alzheimer's disease of the ethnic group of Yakuts inhabiting the Republic of Sakha-Yakutia. What shall we start with? The first step is always the most difficult, to choose the journal or first, or to prepare the article, to choose the reviewer. These are the questions that the young scientist faces. The first step. Before preparing the article, we need to discuss how we are preparing ourselves for the publication. We need to get registered in the ORCID system to get an ORCID unique number that would allow you to go to the system when you send the article, so that there will be no same names, so that all the information was included. To avoid these mistakes, it is advised to register in ORCID. It is absolutely free, and here you can peg the ORCID to your profile website. Speaking about Russia, it is also recommended to register with the Russian base Yelavri. So you have received ORCID, you have received your code, and let's go further. The first stage of preparing the article is to understand what kind of article we are submitting. This is a trivial thing, but very much depends on it, whether the article will be accepted or not, how correctly you will be able to narrate your results. Let us go over main types of articles: original article, review article, case report, brief report, and letter to the editor. What are the features of the original article? This is the result of your own trial. It includes standard sections. They may be different from article from journal to journal, but it's introduction, materials and methods, result, discussion, conclusion. The volume is not more than 5,000 words, but various can be different. But the average is 5,000. The review article does not contain standard requirements for sections. The structures can be is free, yeah, so you can it should be an abstract, structured or not structured. So it doesn't contain the results of the own trials. Does not. So it can be a systematic review. It may be a random review. The systemic analysis ends with the meta-analysis. The volume can be different, up to 20,000 words or even more. If in foreign articles, you can see that the number of literature sources can be 200 and more. In Russian journals, we often have limitations of the number of sources, 50, for example. It's very difficult to fit all the literature into this list. The good review will provide a case report is the description of the clinical case. The volume is not big. It may be one article or series of articles for if we speak about the publication of the clinical case, we often have to attach quality results of trials and some the results of tests. Yeah, so X-ray results, CT results. That depends. That is important. A brief report is very often authors neglect this type of articles, but that's not good. After you have got a breakthrough result, and you need to do everything very quickly, that you are the first to have received this result. And the results received by other scientists are secondary. You have quite a new data. These are the results of your own trial. The structure may repeat the original article, as I have mentioned them. Sometimes there is a requirement to make a destructured article. So the brief report is a description. The idea is to shortly present what you have obtained. So the volume is small, up to 1,000, 2,000 words. The brief report is required when you want to show quickly your results if they are unique. And the letter to the editor very often the condition, the requirement is your opinion of the article that has been published in this journal. Sometimes letter to the editor can be read only for the article that has been published for 3 months ago. Maybe it is 3-6 months. You can write your letter to the editor, express your opinion about this or that article published in this journal, whether you agree or disagree, or you have had some other results. It shouldn't contain any own results up to 1,000 words. Now, translation into English, that's a barrier. For the young scientist, whether to make the translation himself or to apply to professional translators or to ask a colleague who knows English well, or some services from journals and publishing houses. Sometimes the journal itself offers a translation service. The prices are different. Also, there is a system DeepL. It is not just a banal Google translator. DeepL is a special translator where they use neurotechnical technologies, and the translation is maximally correct and close to the original. Of course, it can't translate the entire text, but some sentences, some facts can be translated without a minimum of corrections. But these instruments, technical instruments, are of course secondary, but it is a useful instrument when you try to translate your article. So, of course, the best variant is to make it independently, to use DeepL or English editing service from the journal. I give you an example of the Wiley editing services. You see, 24 hours is for $400. The price is not very high for the correct translation. Of course, the translation is important, and only the article with the correct translation will be adopted. Now the system of scientific citation. So there are two large competitors. It is Elsevier, Scopus, and Web of Science. These are the largest systems of indexing, and the journal can be indexed in both. What is CGR and GCR? The classical impact factors we are used to CGR are calculated by the system of Web of Science. What is the difference? GCR is calculated without accounting for the rating of a single journal. All journals are equal. And Scopus analog is CGR. It is considered to be more correct, more representative, because it is calculated on the basis of the journal rating. The system of search is very convenient. You can see CGR or GCR, yeah, so you can find it here. Here you can make a search by country, by direction, by field. This is the first step. Our article concerned pharmacogenetics of anti-androgens, cardiology, then PPIs. We choose medicine, then cardiology, and we see that the first place is taken by journals with Q1 factor. So let us look, we should look for something simpler, for something lower, because our article will not be accepted by this journal. How to check GCR? The Web of Science publishes such a table in PDF where you will find the impact factors of this journal. The system is not as convenient as in Scopus. So what is more important? Both are important. You can't say that GCR is more important than CGR. So we have chosen a simpler journal, Drug Metabolism and Personalized Therapy, where they published results of pharmacogenetic trials. It's a German journal. What do we do then? We look at the quartile of the journal. All grants require publications of the first and second quartile. It has become a very important indicator of the journal rating. So this journal is in quartile 2 in pharmacology and toxicology. Now look at the dynamics of impact factor. So whether there is a situation that GCR has been reducing for recent years and it will be lower by next year, we need to understand how the journal is moving. Of course, it's better to choose journals where the impact factor is growing, so the rating is increasing. Okay, so we have chosen our journal. GCR is not indexed. CGR is 0.531. It is not very high, but so we have decided from the very beginning to choose a simpler journal. If the journal is not indexed, we look at GCR. If it is indexed in both systems, the impact factor can be different very many times. Yeah, you look, if you say in CGR it is 687 and GCR it is 44. It is connected with the fact that the system is older than this journal appeared in that system very many years ago. Also, when choosing the journal, it is very important. Suppose you have done everything, prepared, translated the article. Now you have to look at the recent articles that were published in the recent numbers. Which articles have been published, despite the fact that it is addressed to the authors, but still I recommend you to look at these articles. It is far from your theme, so some other field is covered, more clinical pharmacological, for example. Just see what articles have been published in this journal. A cover letter is very important. Do not neglect this point, and the well-written letter has a very great influence. And the poorly compiled letter can be the main reason for which the editor will send the article back. So you have to sell your article. You have to justify why this article is to be published in your journal. What is unique about it? What citation will it provide to the journal? Whether it will raise the journal's rating. So you should justify, you can give some references confirming the importance of your article. It is not more than a page. The next page, you should be very careful about dual journals. Invitations to your electronic email to publish your article. Not a single respected journal will write a letter inviting to publish. These are just journals that are fictitious. And we have come across it when I was a student, a famous journal of Pharmacy and Pharmacology of the British Society of Pharmacologists, and it is indexed in both CGR and GCR, but to have received a letter to the email from Pharmacy and Pharmacology journal. So I found the site of this journal, sent an article, but that is the twin journal, so to say, which is not published anywhere, which is not mentioned anywhere. They just have taken the name of the Pharmacy and Pharmacology journal. Not a single respected journal will write a letter to your email with an invitation to publish. That's why I always check the index of the journal, whether it is a real journal. So there are some intermediaries that suggest publishing your article for a certain sum of money. I do not recommend you to get contact them. Okay, so we have chosen the journal. What do we do further on? It is necessary to choose whether we want to publish it in open access or in a closed access for a certain amount of money. What does open access provide? If we pay open access, it will raise an access to our article and will give a better chance for citation. Sometimes some journals are absolutely open access, so more people will see your article in this case. So people won't have to pay extra for reading your article. The next question, in what order authors are to be placed? Who is the first, who is the second, who is the third? What authors do we have? The corresponding author is the one that is responsible for correspondence. So he sends an article and is responsible for the correspondence. There are submitting authors who virtually send the article, and he is responsible for fulfilling all the requirements of the journal. Are there any limitations in the number of authors? Yes, some authors limited to 10, but in most cases there are no limitations. For example, you see the very large genetic article, and you see how many authors are mentioned here. In what order are co-authors to be placed in the article? Yourself or scientific advisor, or those specialists who made laboratory work, or who were more responsible for the article, for the trial, for the volume of the trial. There are different approaches to this sequence. For example, in the alphabet order, or the special importance of the first and the last authors, or in the order of reducing contribution into the work. In Russia, mainly, the scientific advisor is the first, so the leader of the group is the first author. But in some cases, the author himself is placed first, and the scientific advisor is at the end of the list. The belonging of the author, to what, or affiliation, to what, with what organization are your authors affiliated, because they may work for different organizations, and it is important for them that all the organizations are mentioned, or probably if what affiliation they would like to be mentioned. So who is not included in the co-authors, but go to the acknowledgement. No, acknowledgements may include technical and linguistic editors, correctors, consultants, general administrations, general administrative support, and people who arranged premises for trials. So they are not co-authors, certainly. They will go to the section of acknowledgement. So the article has been prepared, we have translated, we have chosen the journal, defined the order of authors, affiliations have been mentioned, and now we go further. When submitting, the problem of submitting is common for all. Information for authors. Then it's necessary to get registered into this system to submit the article, to choose the type of article. The file of articles is loaded, then the file with tables, and the choice of reviewers. The Professor Fingerhardt spoke about it. Very often, the journals suggest you indicate your reviews from 3 to 5. Of course, so you may help the journal find the reviewers for you. There must be specialists of your field who understand your theme so that they could correctly assess your paper. It's just a name and a family name and electronic mail. Then you look at the status of the article in the submission system. We get an answer that the article has been submitted and wait for the response and get the reviews of the reviewers. This is a very good review of the review. So we have received reviews of all reviewers. And a very important issue, how to keep up correspondence with reviewers. So everything has been done, written, translated, chosen the journal. So the most interesting thing is to communicate with the reviewers, where all the situation may stop. The way to the publication of the article maybe look this way. At the end, you see paper accepted, but at the beginning, you go through the reviewers. At the reviewers, editors, and sometimes it looks like this, sometimes it looks simpler. But the reviewers and editors are to be considered as not enemies, but as aids. If the paper has been rejected, don't think that the paper is bad or something is wrong with you and you are frustrated. But it is better to know whether you have been rejected only or many articles have been rejected. You know, only 9% out of 6,000 articles submitted annually have been taken for publication in the Journal of the American Medical Association. Only 9%. So a large number of articles are rejected, 91%. The journal Nature, as you know, declined publications of further Nobel Prize winners for the opening of the Cherenkov radiation photosynthesis work. So Nature has declined their publications, and 2 or 3 years later, they received Nobel Prize for their discoveries. And then Nature came up with tried to excuse itself, made suggestions to publish, but you know, that's why don't get frustrated. You are rejected, but in several years you can become the Nobel Prize winner. So you shouldn't be so very much frustrated in this case. So what is the ideal and the real way of submission? In the ideal way, it seems to us that you have written an article, prepared the material, sent it to the editor looked through it, everything is in compliance with the requirements, and then he gives to reviewers, reviews give a good review, so you have received the comments, sent the article a day, and it has been adopted. But it never happens in real life. The real way is from the moment of the paper going to the reviewer, from receiving the review and the back review, back sending of the article to you, it may take up a lot of time. The correspondence may last for a year and longer. So your reviews are peer reviews, whom the journal has selected. They may be located in any point of the world. Sometimes they are not chosen very correctly, and sometimes the reviewers are not very well aware of the theme, but anyhow, they make a review on your theme. What could be possible decisions of the editor after they have received the reviewer's opinion? So I see the main things. There are 4 main decisions: to accept with small changes, to accept with the major changes. But to accept, you need to rewrite 50%, but it is accepted. Sometimes the paper is not declined, but they suggest that you rewrite the article and to reject the article without the further chance of publication. what are possible scenarios in reviews responses? So reviews can contradict each other. It happens very often. What is to be done in this case? In any case, you have to make changes. You just can't say that his opinion is wrong. You have to choose one of the positions. Why do you think so? And to choose one of the position of the reviews. It happens. Sometimes their opinions are very contradictory. The reviewer is mistaken. You see that he doesn't understand and he makes a clear mistake. He wants you to remake it, but then it will be incorrect. So you need to give a detailed comment and justify your results, that it should be presented the way you did it and not the way the reviewer suggests. So such situations are frequent. So the reviewer is just rude. There are such comments. The reviewer writes that the paper is bad, it cannot be published, he is very rude. So you shouldn't answer then, it won't help us. And one more scenario, when they suggest you curtail your article by 30%. You think that everything is very important in your article, but the reviewer suggests cutting by 30%. So it is not so easy. Sometimes two reviewers give a very good positive comment from the point of view of publication, but the third reviewer is very much dissatisfied. So if there are two positive reviews, the third is negative, the journal doesn't reject, but you need to answer to all the remarks of the third reviewer. There are golden rules of correspondence with reviews. There are 3, 5, 10, 15. All these rules can be united into 3. Rule number 1, you need to respond, to give all full results very politely and with respect to all the reviewers. So if you give full arguments politely and with respect, that will give a very good impression. And it is very important to give a reply to every comment. So you don't write all the answers in one text. The reply should be self-sufficient. Don't make a reviewer go somewhere looking for some materials so that don't make him analyze something himself. Give him everything, the maximally detailed answer to his question, so he wouldn't go anywhere else to look for information. He won't, otherwise he will have to spend a lot of time free of charge. And the third rule, do not afraid to be stand for your position. So don't be afraid to defend your position if you see that reviewer is not wrong. So this is the first monument to reviewers. It appeared not in the United States, not in Great Britain. It appeared in Russia. It stands in the yard of the High School of Economics. When you come, if you are in Moscow, you may go and see. And, you know, it shows 4 main decisions the reviewer can make, to rewrite, to accept, and so on and so forth. What else can be added? Don't forget that the reviewers spent at least 1 hour of his personal time on review reviewing your article. Before you send your reply, ask your colleague to look at your answer before you send it to the reviewer. Probably there are some shortfalls, probably it is too emotional, probably it is a little bit rude. So when you have received the reply of the reviewer, don't answer at once. Switch off your computer for several days, have some rest, and don't respond for 2 or 3 days. Then you come down, you switch on your computer, read these comments, and you will write an answer in quite a different state. So it is a grave mistake, yeah, to write from the very beginning. You may sound rude, and it's better not to do it. Avoid the phrase, we are not at all agree with the reviewer, or the reviewer doesn't seem to know this aspect. Don't use such phrases. Right, we agree with the reviewer, but, and then you may include everything. So don't use phrases like the reviewer doesn't know, the reviewer is not aware. What other special situations are frequent? What to do if reviewers do not accept your corrections? We have had such a situation. I only give you real examples that really happened in life. So we were in communication for a year. They asked to make corrections. Then the new data have appeared 2 months after we sent the article, and the student by mistake included this data. So, and 3 times we had the reply to rewrite the article. We wrote a letter to the editor-in-chief with the justification that we have received the answer 3 times, you know, and they are already introducing incorrect changes or suggest introducing incorrect data. So we put our hopes on the editor-in-chief. We received the answer in the same day, and the article was accepted without any correction, in accordance with the third correction that was suggested by the reviewer. So it was published in the journal, and the editor-in-chief supported us completely. That's why in such difficult situations, write to the chief editor. So we should always try it. So we have, if some serious mistakes have been found in your article after publishing. So this is also a real example. There was a mistake of interpreting one of the markers. It was not our mistake. It was the mistake in the instructions of using this set. That's why we received some contradictory results, and we wrote a corrigendum of our own article where we showed how this phenotype that can be interpreted, the one in which the mistake was made. So it was just published as an addition to the article. That's why don't be afraid to write such corrections. That will be correct on your site. So these are the main reference that I used while preparing this presentation. And if you take all my advice, well, your way will be clearer, will be simpler to the point when the paper is accepted. And finally, why should you look at reviewers as your aides and not enemies? Because the articles that have gone through several stages of reviewing have higher indicators of citation than the articles that have been adopted quickly. So don't be afraid make your corrections. Don't run to another journal to get published. There are data that the articles that have undergone many stages of reviewing have higher indexes of citation than the articles that have been accepted quickly or at once. That's why reviews are really our aids and not enemies that put barriers in our way. We tried, and it is really successful. That's the example of articles that we published in journals Q2, Q1. These are the publications of the 2018, 2020 in the journal Pharmacogenomics. This is an example that Web of Science and Scopus sometimes tell others how to publish an article, although they haven't published a single one. No, I am just showing you that we have tried all these tools and they are really working. This is our team. Thank you to our team, to our scientific advisor. If there are any questions.
Yes, okay, I am listening. Thank you. Thank you, Karen, for that talk. That was very interesting. A little bit of an overlap with what I'm going to talk about in a few minutes. But that's okay. Repetition is something that's good for education. Okay, so as I said, this is going to be a little bit redundant to what you have just heard, but maybe I'll go into a little bit more details. And because of the repetition, maybe some of the questions that you want to ask can come up, and we'll try to answer them as they come up or at the end. We've heard about the considerations of the peer review process and the fact that there is an enormous volume of submissions. You heard that one journal only accepts about 9% of the papers that they receive. Very high impact factors. Journals are like that. The Annals of Surgery is something like 10 to 15%. So indeed, the editors and the reviewers are looking for reasons to reject, not to accept. And it does lead to a sort of negative mindset of journal editors. The other question is that everybody is pressed for time. The editors and the reviewers are no exception. Let me go through the typical steps of the peer review system so that you could perhaps understand what the process is, how the process sometimes gets complicated, and how sometimes the process is slow. When a paper is submitted electronically, this is a typical situation. The editor gets the paper. Now, some editors are very conscientious people, and they read the paper. I can say, for instance, that when Alfred Kashiri was editor-in-chief of Surgical Endoscopy, he, at least at the beginning of his editorship, read every single paper, or at least scanned through every single paper before he started the review process. I am not sure, and I'm almost sure that this is not the case for most editors today. Alfred Koshiri had a very particular characteristic. He only needed 2 or 3 hours of sleep every 24 hours, which is an enormous advantage. So he had a lot of time during this 24-hour span to do a lot of things. Anyhow, any normal person is not like that. And so it may be that the paper is not seen in detail by the editor. Sometimes, as I said, it is possible, and the paper is accepted directly by the editor. Very exceptional. Most of the time, it will go through the peer review system. And now, that peer review system is a little bit more complicated than it used to be. The usual system was that the editor sent it to a section editor or to the peer review directly. We'll talk about that in a little while. But nowadays, the editor can also suggest another journal or the open version of his journal, or reject the paper outright without review. Let's take that situation into consideration right away. Usually there's a standard letter saying there's too many papers, and the journal thanks you very much and so forth. But we to have too much volume, too many good papers, we cannot accept it. And there is usually no comments. This is something I do not agree with. However, we have to deal with it because it's real life. The editor may suggest an open version of the same journal or another journal, usually another journal in the same editing house. Take advantage of this if you believe that your paper is worthwhile. You've heard this before. You've heard this in the talk that we just heard. If your paper is accepted outright, fantastic. Champagne. However, most often this is not the case. And as I said before, it may be rejected, may be accepted. And you get things like this also that you might want to transfer. Everything on the web today is very user-friendly. And as you have heard, the editors don't like to reject the paper outright, but they just have to do it because it's time-consuming and they have other activities. As I said yesterday, the academic surgeon today has teaching responsibilities, he has operating responsibilities, and he has research responsibilities. Somebody who's doing an editing process, he's doing that outside of all those three academic activities, which already take up most of his day or her day. And then people also have family lives, they have children, they have other things to do in life. There's only 24 hours a day. If you're not like Alfred Kirchner, you can stay awake for 22 hours out of 24, like most people are. There's just so much you can do in one day. So if you get the suggestion of transferring and you think a paper is worth it and you get some review, some sort of review, take advantage of that situation and transfer. The transferring system is something to remember let's say that the advantages of the transfer system is First of all you have to do, it's on the web. They send you to the site. All you have to do is click, yes, I want the transfer system to work. You might have to revise your cover letter, but it doesn't take much time. You're under control. The decision is transfer is yours. And the reviews that have already been done, even if you have not received them, will be transferred automatically. So it is a time-saving procedure. The process is very simple. The journal is up to your choice. They propose a list, either the open journal or another journal of the editing house. And the system is automatic and immediate, as I said. Otherwise, you can decline the transfer, submit to another journal of your choice. But you have to go through the whole process once again. So now let's take a look at the editor or the section editor that sends it to peer review. Here again, you might get an outright rejection with a good review or a poor review. You take advantage of the good reviews. You can take some advantage also of peer reviews, as we talked about yesterday when we were talking about the process with Michael. Even if it's a poor review, even if it's written in poor English, you have to say to yourself, well, something was not understood. So let me rewrite it again, even though I don't agree that there was something wrong. Let me rewrite it again. I may have missed something, and there might be something that I can change. The other option, of course, paper is asked for revision and it's not rejected. It can be accepted, but say, we are interested in your journal. Would you take a look at the reviewer's comments and make the revision? We will reconsider the paper once these revisions have been made. The revisions can be minor, they can be major. If there is major corrections to be done, I agree with the speaker this morning that don't rush into it. Take your time, think about it, read it first of all in detail, digest it, and then think about it, and then at a later date, not too late, don't lose too much time, go back to it. Review it clearly and revise it. And we'll talk about that in detail. You've heard that rejection is not a failure. It happens to all of us. And it should not ever be regarded as a personal criticism. Don't take it as a personal criticism and leave it. Think positive, think what you can do. You've heard of the Krakonoff paper, but you also should realize that the Krebs cycle was also rejected by Nature. Eventually, of course, it got published, happily for us. The Cherenkov paper we talked about this morning, rejected, but then revised. But it also happened to the Yuko Asmazin paper, also a friend of Einstein, and even Stephen Hawking's black hole radiation. Same thing. So very famous scientific papers outside of medicine have been rejected. Nobel Prizes, since we mentioned that as well, were originally rejected, and then the Nobel Prize came. You've heard this morning as well. And very recently, the Nobel Prize winner of Peter Radcliffe. I have here on the left, you can see the original rejection from 1992. It took him almost 20 years to get the Nobel Prize when he persisted and got the Nobel Prize on the same topic of that he wrote in 1992, and the paper was rejected. So, along with other publications that have been rejected in outside of the field of medicine, very famous papers like The Lord of Flies, The Spy Who Came In From the Cold, The Diary of Anne Frank, Catch-22, Harry Potter's, Animal Farm, Sanctuary, one of my favorites. All these original manuscripts were rejected, not like the Bronte sisters that I talked about this morning. So your decision what to do depends on the type of rejection, the journal that you're looking for, that journal that you looked for, type of article, as you've heard, how long it's going to take you to correct it, and exactly what the reviewers wrote is something that you have to really digest and take into very serious consideration. Should you repeal and submit? This is something you have to think about. It's not common, but it sometimes can pay off. Throw it away? Certainly not. Send it elsewhere? Yes, but then you have to decide where. Now, repealing the decision for that first choice journal. This happened recently, and maybe even Professor Katkoff was one of the co-authors of this paper that was originally rejected, and an appeal was made, and the paper was finally accepted into Annals of Surgery. And in the bottom here, you can see the editor's intervention, the editor-in-chief, who actually intervened, and he overruled the review and came up with the acceptance. So here you see the acceptance letter. So in general, don't give up. There are many other journals. And one of the main trump cards is that the referee's reports, when they are good or even bad, always lead to improve your paper. Even if they are poor, as I said before, it should incite you to rewrite what the reviewer seemed not to understand, and you will improve your paper. You choose another journal, you change the journal style. Don't forget, it's very improper to send a paper that's supposed to be revised to another journal with in the indications of the first journal. I have even received papers that have been rejected, and in the cover letter was the same cover letter they sent to the first journal. They just changed the name of the editor, but they didn't change the name of the journal. So be very, very careful. Don't be sloppy. As we said yesterday, the word sloppy in Russian, I don't know what it means in Russian, but it's a very important word. Don't be sloppy. Be very, very careful that all the details, you pay attention to the details. So when you choose a new journal, you have to go through the MEM process. Should you look for a higher impact factor? Sometimes, why not? If the peer review has been sufficiently complete and it really improves your paper, why not? We'll see some examples later on. Usually you go for a lower impact factor. The other consideration is the topic. It might be that you have to change the title in order to attract the other journal. Think about the idea. This is something that I do very often when a paper is rejected. I correct it according to the peer reviewers' opinions, to their ideas, to what they understand or don't seem to understand, as I said before. But very often I will change the title. I will change the title in connection to the general gist of the reviewer's corrections. I also consider how much time I'm going to need to do the corrections. That's something that you have to consider very early, because it might take a few hours, or even sometimes up to a whole day or 10 or 12 hours to correct. So you might have to consider that in your daily schedule. One thing I do right away also is to look at the references from that second journal to make sure that if there are papers that are similar that have come from another journal, I want to make sure that the papers that are from the second journal are included in my reference list. Do not forget that journals are looking for ways of improving their impact factor. And sometimes indirectly, maybe not the peer reviewer, but certainly the editor will look. There are people in the editing house that will look as well as how many articles, how many the references in your paper come from the same journal that you're submitting your paper to. The higher the amount, I know this is not very scientific, but the higher the amount, the better chances you have of your paper getting accepted. We talked about the impact factor. Lower impact factor is a wise decision, but it can be a higher impact factor. And once again, you have to take into account the degree of specialization and the readership. Take into account the revision comments, the style, the presentation, further statistical analysis. Not a problem, really. You can do that very easily and very readily. More difficult is when you have conceptual criticisms, methodological considerations, and experimental design considerations. There, you're in a more difficult situation. Once your study has been completed, it's no longer possible to go back to the original laboratory and set up and do another experimentation. So you have to find some way of modifying things. And that comes from changing the title, changing the focus, changing the discussion to orient the new paper to the criticisms that have been made about the concept, the methodology, or the experimental design. You can't change those things, so you have to change the goal of your paper and the journal that you want to send it to. Something else you have to deal with and admit, and that's the mindset of you as an author. You have to admit that the criticisms are well-founded. Even if you read them and you say, why did he say that? Why didn't the reviewer understand what I was saying? You have to put yourself into question. You have to say either something is basically wrong that I missed, or difficult because it's difficult to understand. It's going to be the same thing for the reader. It may be also that the reader has another idea. I don't think that we should reject anything by the reviewer. If he makes a comment, something is inherently wrong with the way the paper went across. And you should do something about it, whether it's for the same journal or for another journal. We said it's very difficult to repeat experiments. As I said before, acknowledge the weaknesses, explain the rationale, do something different, and then go to another journal. Yes, we've said this before, sorry. If the criticism is justified, change them. Try to understand what the interpretation difficulties were. Go to your senior author. This is where a senior author really has a very important role. Go through each point. Decide whether you want to argue the point with the editors or not. It's okay to do that once in a while. Certainly you can't do it for every criticism that was made. But this has to be done with your senior author, your senior advisor. Can't do it by yourself. Rejection because of language and styles. Well, reviewers are not always good judges of language and style, as we've seen yesterday and we've seen this morning. So there are editing houses. We've heard about that. There's editing sites, but be very careful where you go and how this is done. And one thing I would add, that's not on the slide, is that once you have gone to an editing house or a reviewing translator, reread your paper. More often than not, as I said, like ghostwriters, these rewriters, these people that work in the medical writing field are not doctors. And they may make very serious mistakes in the translation or the interpretation in order to do the translation. And this, of course, is unacceptable. And you have to find a way of dealing with that by yourself. Now, when you resubmit, make sure that you use the correct house style. Otherwise, you are making an insult or an offense to the alternative journal. And it's going to give an impression of imprecision and sloppiness to the new journal. One thing that is, I talked about yesterday, make sure that you, if you go from a English-speaking, a British English-speaking to an American English-speaking journal, make sure you make the transition with the spelling. This is something that will give you some more value. Okay. Even if you get a second rejection, don't give up. The same process is in order. Now, don't lose time. Time is very precious. You have to keep this in mind, that a paper that's going to take 2 years to be published here, as you see here, the interest is limited. Your data was accepted for publication in 2005. The revision was so process long that it was actually published in 2007, almost a year and a half afterwards. That's really a pity, because the information gets what we call stale, like bread gets stale. Usually when you get a request for revision, there's a time limit, somewhere between 2 and 3 months. Be very careful about the deadline, because if you go over that deadline, usually you get a reminder, as a matter of fact, but if you don't get a reminder and you go over that deadline, your resubmission is going to be treated as a new submission. You're going to have to go through the whole peer review process again, and this is going to be a problem for you it's going to take time, and it's going to be a question of rejection. Let me go further. If there are questions that you want to contest, you've heard this before, you have to be very polite about the way you do it. The editor may refuse it right out. Don't forget, when you revise, you have to rewrite a cover letter to the editor and a cover letter to the referees. We'll talk about that. The referees usually will get the paper back with your corrections, but sometimes the editor will call for another referee. And if that happens, it's going to increase the delay to publication. And more importantly, and more problematic, this is another opinion. The other referee is going to make his opinion, he's going to make his corrections, he's going to ask more questions, and again, we are going to delay the process and even lead to an outright rejection by the third or the fourth referee that was not called in the first time. Unfortunately, this happens. So as I said, we have to deal with all the referees' criticisms in the cover letter to the referees, as well as I always do it to the editor as well. Whether I agree or I disagree. You have to itemize each comment and request, and each item and request has to be dealt with individually. Don't get emotional. Don't get argumentative. Just say, we agree and we have decided that we corrected it too. We disagree and give the arguments, or you thank the author and then you say, I'm going to review the process, as we've seen the examples before. Here is an example. For instance, reviewer number 4, the comment, what I do is this was required by the journal. They wanted a table with the first column, the reviewer's comments, the author's reply, and the alterations in the manuscript. But even if this is not required as a table, this is what I do. I repeat word for word the reviewer's comments, or at least I cite the author should state whether the distance, as I said in my letter to the editor, to the cover letter that I talked about this morning, The reply always gives some sort of a complimentary gist to the reviewer's remark. Explain if you need in a different way from what you wrote, and say that this has been clarified, and then give the alternative, give the alterations that you made in the manuscript, write them down. Don't be afraid to repeat what was done and then give the answer to what you did. The reviewer is pressed for time. He doesn't have the time. He doesn't want to go back to the manuscript and try to find out what you're talking about and where you're from. Even sometimes, instead of saying patient emetic session, I would put the page number on which the changes occurred. Even the page number and the line number. So we have a cover letter to the editor saying that we revised the paper accordingly. We have a cover letter to the reviewers with their comments, our reply, and the alterations that we made in the manuscript. We send in two different versions. A red version, what's called a red version, it can be any way you want it, where you see the original paper that you sent in with the corrections, what you corrected. And then a clean copy where the corrections have been taken out but have been added to the original article. So we have four different, let's say, things to submit. The cover letter to the editor, the cover letter to the reviewers, the red version, and then the corrected final clean, what they call clean version. Another way of doing it is after in-house revisions, and they usually come in the form of queries. Sometimes you get this after your preparation, your paper has been accepted, and these are proofreading remarks that come that have not been seen by the reviewer, but have been seen by the editing house. Once again, the same thing. You have to answer these questions, and here the problem is they usually want that back within a week. You don't have 2 to 3 months for this. Whatever, when you're waiting for a decision, under no circumstances do you refer to your article as being in press. You only can say that your paper is in press once you have seen the letter of acceptance. Do not do that. As I said before, I said it this morning, I repeat it. All too often, you think your paper is going to be accepted because you've done the revisions. It's not accepted. And if you put it into another paper and it's cited as being in press and it was not published, first of all, you're going to be responsible for that. Second of all, it's false information. So let's take a look at what happens to papers that are rejected so that you have a good idea of why you should persist and keep on, don't lose sight of your publication goal. Somewhere between 40 and 65, almost 70% of papers will be eventually published. This is the result of an analysis that was done in 2010. But I probably, if I updated this today, I would say that the rate of papers that are eventually accepted is just a little bit lower. However, if you change the title, if you change the scope, if you change the focus, I think the acceptance rate will be much higher. The re-acceptance rate, let's say, it will be much higher. So going to this paper in 2010, this is the articles that were rejected by British Journal of Surgery that were eventually published in other journals. Now, I'd like to draw your attention to the fact that at that time, in 2010, the impact factor of the British Journal of Surgery was much higher than all of these journals here, except Annals of Surgery. So you see that one paper that was rejected from British Journal of Surgery with an impactor of about, I think it was about 5.2 at that time, eventually got accepted by Annals of Surgery, which is a much higher impact factor. Even more impressive, some of these papers, here's the paper of Annals of Surgery again, some of these papers even went to papers outside of surgery because of the scope, and got accepted also in papers that in journals that had a very high impact factor, even got almost twice as much as, or over twice as much as the British Journal of Surgery at that time. So this is to encourage you not to give up and to keep on going. Resubmission, as a conclusion, I have to insist on the fact that the letter of rejection and referee's critiques always contain important pointers to the rewriting. It may require some skill and experience to construct a suitable response, but once you start doing this, you get good at it. It's a skill that you acquire, and you acquire it fairly quickly. And once you have acquired it, it's good forever. It's a very interesting process, as a matter of fact. I like it quite a bit. The aims of publication are educational. The aims of peer review are educational. The dissemination of new knowledge, technology, is going to influence clinical practice, can only benefit from this review process. You have to take this review positively. And the selection of the appropriate journal of the first is as important as avoiding rejection of the idea in the first place. The most difficult task is to get an idea published. You and the editors are responsible for that. You know what's already been published. You know where there's a place for something else. Medicine and science are replete with stories of initial rejection, as we've heard. And the invitation to resubmit can only be something positive. And have that positive mindset is something that will lead you to a better academic career. Okay, I have finished with that. Is there any questions about what I've just talked about?
Everything seems to be clear. Thank you.
Okay.
When you speak about...
Yes, go ahead. Go ahead.
No, I mean that when you speak about this, everything seems to be clear and understandable.
Okay. I'm a little bit ahead of time for the next talk. I've talked about corrections. I've talked about resubmissions, how to deal with successes and failures. Just give me 2 minutes. I want to talk to you about ethics, which is not on the program. But I think it's something that we have to, or referencing, I'm sorry. I want to talk to you about referencing, which is not on the program. I think it's something that's very important that we have not dealt with, that we have to talk about. So if I go correctly to here, once again here, and then, no, here. Can you see my slides referencing?
Yes.
Okay. Why do we need to provide references? Think about it. First of all, it's demonstrating to your readers that you have conducted a thorough and appropriate literature research and carried out what we talked about this morning, critical appraisal of what you have read. It's also acknowledging that you have used some ideas or written material belonging to other authors in the paper that you're writing. And last but not least, it's a source that you give the reader if he wants to read the original paper as a source of further research. And other future authors will use that for their own research, like you use the references from the papers that you read for your research. Referencing is commensurate with good academic practice. It's an acknowledgement of a fraternity, of a brotherhood, of the surgical or the medical community to which you belong. It actually enhances the presentation of your work. Don't be afraid of acknowledging that somebody else had an idea before you did. It shows that your writing is based on solid, sound, methodologically correct knowledge, and that you have done the appropriate academic reading and critical appraisal. And it ensures that people can use those sources, and especially that you have not taken those ideas as your own, and you have acknowledged and given credit to the original authors for their research. Nothing would be worse to cite an idea and not give a reference for it. When the original author reads that paper, he's going to explode. And if it's somebody well known, it may well destroy your paper for future publication. Even worse is if you use, and we'll talk about this in a little while, if you cite somebody word for word without giving a reference, this is called plagiarism. And plagiarism is a very serious demeanor in the publication world. we probably don't have enough time to talk about that, but I certainly can give you some examples. So now referencing in itself is composed of two parts. There's the citation, now when you refer the reader to other works in your own publication. And then there's a reference list, what you have read in order to write your paper. These are the same citations, of course, but they're two different compositions that I want to deal with now. So for one, how do you cite? The cite is a connections statement. And this connection statement is acknowledging that you have used an idea, a finding, or a methodology that is not yours, and that is part of your scholarly method of joining other related published knowledge. So this is a tricky situation that people don't really pay attention to. And I would like to insist on this slide, which I think is one of the most important slides of this talk. You have to make a distinction between what we call primary and secondary papers. Primary papers are original articles, original research papers, whether they are clinical, comparative, randomized, case control, cohort studies, or even case series. Whereas secondary papers are systematic reviews and narrative reviews, systematic reviews, and meta-analyses. Do not forget that systematic reviews, narrative reviews, and meta-analyses contain the primary papers. So it's completely illogical to cite an original paper and then cite a meta-analysis where the original paper is already cited in the meta-analysis. You've already cited it separately. This is something everybody considers meta-analyses as a equal to an original paper, or even sometimes even better. But they do cite original papers, primary papers. Okay? Be very careful about that. This is one of the errors that I correct all the time, and I have a long list of papers that I have reviewed and corrected in this aspect. Okay? Am I making that point clear? Second, cite only the articles that you have read, that you have chosen for their quality of information or the methodology. Cite them without any interpretation or changing the message, and don't use secondhand references. What are secondhand references? Does anybody know what a secondhand reference is? Okay.
I think that everybody is waiting simply for explanations, but I think that everybody understand that it's simply this citing of citing.
Exactly, Igor. Be very careful. When you see and read a paper and you see that an idea has already been cited by somebody else, don't just cite the person that from the paper that you're reading. Go to the original article. Unfortunately, and this is one of the big problems with publication, you will see that the paper that you're reading is already a secondary reference. In other words, the person did not cite the original paper. It's not that difficult, once you are familiar with the literature, to find the original article. Only cite primary papers from the original citations and don't cite secondary references. The problem with secondary references is that every time the paper is cited, the interpretation of the person who's citing gets misinterpreted every time it's recited. So finally, the original idea is deformed to a point where the information is false. One of the most exemplary examples, one of the most prominent examples of this that I don't have a slide on it in this talk, but I have a slide on it in another talk. And I'm sure that Igor and many other surgeons interested in pancreatic surgery will recognize at one point, there was a randomized trial coming out of John Cameron's group in Baltimore comparing the use of octreotide, or not comparing, but yes, it was octreotide to placebo, I think, in the role that octreotide would have in preventing pancreatic fistula. The first author of that paper is a very prominent mentee of Cameron. Not going to mention his name, that doesn't matter. But if you read the original paper, it was like the paper we corrected this morning. There was supposed to be, I don't remember the numbers, but let's say 250 patients. They stopped the study prematurely because they had a referral problem. So the study was underpowered. Underpowered studies means you should not come to a conclusion. They did come to a conclusion, but the first person to cite that paper, because it came from such a well-known surgeon and from the house of Cameron, let's say, no one ever put into doubt that they were not, the methodological aspect of this paper was not correct. And this paper gets cited and cited and cited again and again and again as the reference saying that octreotide did not work. The paper was written poorly. It was written poorly in the aspect that it was underpowered. They said it was underpowered in the methods, but they still came to a conclusion. So this is just one example of how secondhand references become the Bible if you don't pay attention to it. So everybody, even everybody in this room, everybody listening to me, you young guys, you're the future of our surgical community. You have to be conscious of these mistakes and make sure that you do not fall into the trap and continue along those lines. You have to do this very carefully. Once you choose your references, don't cite 35 references of a single statement. Try to go to the original paper, find the original paper that did it. If there was a modification of that information, yes, that can be a second reference that you can put there. Try to use the most powerful reference on the topic, either it's the original one or the most, let's say, biggest series on that idea. Recent references are more powerful than older ones. References from a high-impact factor journal are more powerful. So these are all considerations that you have to make. Obviously, if it's a randomized clinical trial and included in a meta-analysis and a systematic review, that also adds to the power. And I put it last, but it's certainly the least. It's not last but not least, it's last and least. Well-known and respected authors seem to be powerful, but they have to be well considered, and they, just because they're well known and well respected, they still have to be analyzed with the critical appraisal that we talked about this morning, sorry. So this is the first part, how to choose the references that you put into your text. Now I'm going to talk about how you, well, first of all, how you cite. I think I talked about this yesterday a little bit, but I want to go a little bit more into detail. When you cite the paper in your paper, do you cite the author's names or the most commonly used way of doing this would be "and colleagues" or "et al"? Or do you do it in another way? I think "et al" is the most widely used system, and it should be the way to go. However, the exceptions are if there's only one author, then it's very difficult not to cite that author. Two authors, you only cite two. After two authors, you cite "et al." I cite this because this is something also that happens that should never happen. You don't cite more than two authors in this way. If there's more than two authors, as I said, it's the first author, "et al." But the author of this paper cited Bill Hield because Bill Hield is a star. And he wanted to make sure that everybody realized that he was citing the paper coming from Bill Hield. But this should not be accepted. So it's not acceptable. So what else can you cite? You can cite the first author, but you also can cite the journal. I don't agree with this. I think this is not a good idea. You can cite the type of study. Well, it may have its importance. Some people believe it's debatable, but I personally believe that sometimes it's worth it, especially when you're comparing your study, your type of study, being something different from the study that is being cited. In other words, a cohort study, and your study was a randomized clinical trial. Well, it has some importance to cite the fact that it is a cohort study. The year of the study, I don't believe that that's very important, but it may have its importance if you are trying to compare or do a historical comparison. Obviously here, if this was a paper that was published in 2020, the fact that you're looking at a 2010 study, people will understand that the paper that you're citing is 10 years old. The other ideas that can be put forth, and I believe are probably the most important, are the information, the idea, or the results, or the conclusions. These are more important than the other types of citations, of the expression of the citations. There are some examples. But make sure that you read the entire paper yourself, no secondary references. And whatever you do, when you put that paper into your reference list, make sure that I would advise that you recopy that. Don't forget that when you cite a reference from the web, there are parts of another paper, there are parts of that reference that are active, that are a link, in fact. And if your mouse goes across them, they light up. When you put that into your reference list, for many reviewers, including myself, it means maybe it's an indication that you have not read that paper. And I would really advise you not to copy and paste references from another paper into yours for two reasons. First of all, the fact that when the mouse goes across and it becomes active means that you have copied and pasted it. And second of all, it means that you have not checked that the reference is correct. If you have got the reference from one paper and you want to cite that, read that paper yourself and make sure that the reference that you got from the first paper is the correct reference. You will be surprised once you start doing this. And I can tell you from my experience that maybe 20%, 1 out of 5 references have something wrong with them. Either the pages are not correctly cited, the journal has a mistake in the volume or in the title. It's just unbelievable how many errors occur. And this is perpetuating these errors if you just copy and paste. It just takes a few seconds to correct. It's not that big, not a big deal. Something about the order of citations. Now you have to look for the instruction for authors. Usually papers are cited in chronological order. Make sure that order is respected. Here you see an example of 16 that comes before 14. More than likely, this paper was submitted to a first journal, was rejected. The author made corrections and changed the order of references, but he forgot to change it in the text. This will be considered as sloppiness. Be very careful when you revise to make sure that the references get cited in the correct order. Citations are usually referenced with an Arabic numeral written as a superscript. Please avoid, or in square brackets, please avoid round parentheses, round brackets and parentheses. There's always a confusion between items. So use superscript, use square brackets. Do not try to avoid round brackets. Now there's another issue that I have a quibble with, and I'm going to end there because if I'm correct, my time is up for that talk, is where do you put the reference? Do you put the reference in the middle of the sentence, or you put it as after the last word? And do you put a dot after or before the reference? I just cannot agree with the idea that the dot comes at the end of the sentence and then the references is after that. I want to put my reference before the dot, but that's just a quibble of mine. I'm not making a big deal out of that. However, I do believe that it's important that you look for the instructions for authors and see whether there is a problem of putting the reference in the middle of a sentence, in the middle of a paragraph or not. I believe that the reference should be exactly right after the idea, right after the author, and not at the end of the sentence, even worse, at the end of the paragraph. I hope I'm making myself clear. I'm sure I have an example, but I don't have it in the order that, let me try to find it very quickly. Here, okay. So you see the example here of a reference at the end, and this is correct. It's before the dot. Okay? This is how it should be. However, what I don't agree with is the fact that wind, which is the author being cited here, is in this sentence here, even though they is wind, obviously. and the citation comes only after the second idea, I would have put the 20 here after the first time I cite wind. I'm sure no one's going to argue with that. And for me, this is more correct because when I read this, I see wind, of course, and then I say they found, and then I see the citation. Okay. But if I want to look at that, I have to look back and find out where that idea comes from. And don't forget that if I cite 20, if I cite an idea from 20, I have to remember that there are two ideas that came out of that publication, this one and this one. So be very careful about that when you analyze the literature, but also when you use the literature for your own purposes of writing a paper. Just a few words about the list of references at the end. This is, we've talked about the citation in your paper. Now, the list of references at the end of the text, very rarely at the bottom of the page, but most often at the end of the text, should include only those publications that are cited in the text. The order and style can vary from one journal to another, but usually, if there's no specific indications in the instructions for authors, usually you have the last name, the family name, no punctuation, the initials of the first name without any punctuation, separated by a comma, 3 authors, if there's 4 or less, all 4 authors get 1, 2, 3, or 4 authors get cited. If there are more than 4, only the first 3 get cited. And then you have et al. Some journals require a colon. Some journals require nothing. Then you have the journal name. Here is a title and a subtitle. Punctuation, usually a dot, sometimes nothing. The name of the journal. No punctuation between the name of the journal and the year of publication. Semicolon with no spacing. The name, the number of the volume, no spacing, colon, first and last page. This, I think, is ridiculous. There's no reason for a dot here, but you see it all the time. I don't know why people do that, but that's it's a secondary problem. One other indication, and I'll end there. If you will look very carefully at this reference here, you will see that the hyphen between the first and the last person, first and last page, is longer than usual. A hyphen, an ordinary hyphen, is much shorter. And what that means is that that reference was copied. I can tell, this is a tip, I can tell right away when I look at a reference and I see that the hyphen is longer than it should be, I can tell that this thing was copied and pasted. This is something that happens with electronics that I've learned over the years. And it means that the reference may not have been read by the author. So it gives me an idea that I have to look into the paper a little more closely. Okay, so I think I've given my talk in the time that was allotted to me, and I thank everybody for their attention, and I'm open to any questions. Well, then I give my, it's 2:30, right? 2:35?
2:35.
Yes. So I give my my spot to Dmitry to give his talk about the grants or how not to get grants.
Спасибо вам, что разрешили.
Thank you, dear colleagues. Good afternoon. I will tell you how you may not receive the grant. Of course, the topic of my presentation is reverse. I want you to avoid the mistakes and to receive a grant. So how this mechanism looks today? There are several funds, main is RMS, President's Grant. There are several other grants, private grants, but mainly we work with RMS and the President's Grant. They pay money for research through the organization. Making your trial, you report to the fund that paid for your research. That's how it looks in the picture. The grant activities, you send your request, and it doesn't mean that they will approve it. Be ready that you improve your request, change your request, and participate in the next competition. If you have a large trial, it's better to have several requests for parts of this trial. There are many competitions, there are different competitions, and one and the same request cannot be presented for competitions in different funds. That's why you look like Sisyphus, who moves his stone up. Of course, there are failures, but you may win grants, and I have such an experience. First of all, you need to write your request for a grant. It looks awful, so to say, but let us think with what we start. We write the plan of the scientific project. We write what results we expect to receive. If we do it very well, then we will lose because we should start from a different angle. There are things which are much more important, the leader and the team. That's what you're supposed to know about your project. All the other things will follow: context, methods, expected results. First of all, make it clear who is the leader, who is a team. The leader of the project may be your senior colleague, more experienced, and he will be responsible. But since de facto you will be leading the project, it happens sometimes. That's why look at the requirements of the competition. What are the requirements for the leader? Whether you can be the leader or your scientific advisor may be the leader. The President's Fund has a special grant competition for young specialists, for young doctors, and there is an age limit in these competitions. The age of the leader is very important in all requests because the percentage of participants up to 35 years is always taken into account. It should be not more than 35 years. That's why you should have people younger than 35 in your team, so that the team would look suitable for the fund. And what obligations are you undertaking? The grant fund would like you to publish articles in the international press with citations of the fund. That's why I think the grant is given for 2 or 3 years. Will you be able to write and publish the required number of articles, 2, 3, 8 articles that are required by the fund? So if you win, for example, you undertake an obligation to publish a certain number of articles in international journals. So there is an organization, and what organization will ask for a grant? Is there any organization that is ready, that agrees to submit a grant? Does this organization have conditions for performing the project? You cannot have one organization that wins the grant and the other that will perform the grant. That will arise a lot of questions. Or you will have to buy the required equipment for the money that the grant will allocate. And red tape. If red tape is very high, close to absurdity in this organization, I wouldn't risk dealing with them. Otherwise, it will be a lot of headache in dealing with this organization. So now the science is funded by grants, and we should know all the rules. Then the idea of the preliminary scientific work, that is the trials that have been made before on the same theme, and the new work is its new project, is its logical continuation. So the leader must have a definite number of articles and focus on the theme of this project. It is taken into account that the leader doesn't just have publications, he should have publications related to the project. Whether you have developed and well-established methods, and the most important, that the research for which you want to get a grant is already started by you. So you, if it is blood, for example, you are already collecting this blood, you are freezing it, and this blood will be analyzed during the trial for which you get the grant. So then the fund people know that everything was okay, that you have already started, and now you will be able to continue. And these are the components of the ideal request. Whether the leader is in compliance with the fund, whether you are sure of your organization, whether the methods that you have stated will be able to be performed. Is there any, have you already started the trial? Will you be able to to collect sampling for a short period, and whether you will be able and publish articles in the required number. So let us return to the methods. Are you sure that you will be able to perform them? Are you sure that the articles are published? So that these are the components of the ideal request. Now you will come to the composition of the request. So you are to write a short review of literature on this theme. And the parts of this review will be read by the reviewers and make comments. They say that they very often write that in the review of literature, you haven't disclosed the theme and that means you don't know what is happening in the world. And you are supposed to keep this review because it can be used by articles used by your students to write articles on this theme. That's why don't neglect this work, the compiling the review of literature. Then you write goals and objectives, you write materials and methods, the expected results, and you are supposed to prepare the plan of work for years. So how many articles will you be publishing in accordance with this plan? You know, in the request, you will just write the total number of articles you will publish, but here you write a plan. So this plan of work for each year is very important. If the request is submitted in December, the competition finishes in March and April, you win it, and you will write the first report in December. That's why it is less than a year. That's why the first year is very important, and you are supposed to write in the plan what you are supposed to do and include the work that has already been done. And how many patients you will be recruited, for example, by September. So if you select more, that will be recruit more, that will be okay, yeah, but this number is to be stated. In the second year, you are supposed to collect all the material because you will have to work more now to write papers. So your efforts are to be concentrated on writing papers. That's why we start doing everything from the first year, continue in the second year, and then the third year. For the third year, we leave the most complex methods, and the maximum effort is put into writing articles. Now the budget of the request, it has some informational character. You just state the list of equipment and agents you are supposed to buy, the expected remuneration of participants, other expenses. So this reward is defined by, so it's about 40% remuneration, 40% of the total amount of the grant. But if you want to buy more equipment, then you can sacrifice your salaries in the first year and invest most of the money in the equipment. So I say that the budget is only informational here, so that the reviewer would just assess whether you are adequate for the grant. Then the timing of the request. The competition is announced a month before its deadline. So in 5 days, you should have in your head what you are supposed to write about. You know whom you would recruit, how to recruit, and define the tasks. Then you write the request. Now I write a request much quicker for 6 or 7 days, 1 or 2 days. I ponder over it and then I write. But it is not more than 2 weeks because you may already forget something. That's why just write it, rewrite it, yeah, think of the better variant. The translation takes up 3 or 4 days. It was so some years ago, but now it is done much quicker. We discuss with the interpreter everything online, and it takes not more than 1 or 2 days. Then we check the request that we have filled in all the forms. And the request is to be done in Word on your own computer. We do everything in Word. So they describe everything in Word. Translation is in Word. And then you make a copy paste into the request form. And then leave one then for yourselves to check the request very quietly, without haste. There are a lot of small things you have to take into account. So take up one day to do it. And then 2-3 days for the final check, so that you could have all the documents signed, press all the buttons that are required. So finish up your request 5 days before the deadline. And they spent these 5 days on very quiet submission of your request to the fund. If it is a paper version, you will have to bring to the fund this paper copy of what you have done. So this is DeepL translation, free. It is better than Google. I have been using it for many years. And last time I translated my request for several hours. The only trick, you insert text in small, large pieces or in small pieces, and then get it back, because you will have to check the English language. But it is much quicker than insert large pieces of the text. Of course, the translation is not ideal. And after you have submitted, starts the things that you cannot influence. This is the shadow side of the request submission. And then you see the list, whether you have won or not. If you don't win, so they send you a review. The assessment is high, the appraisal is high, but they haven't given you a grant. Suppose the reviewer didn't understand your request and wrote very many remarks which are not have nothing to do with the paper you have written, so there is no solution. You cannot prognose how the reviewer will understand your request, what kind of review it is, and how finally the decision on the grant is taken. You can never understand why they haven't given you a grant. But there is a problem we should discuss on each platform about blinding the requests for reviewing. Because now the reviewer knows to whom he writes, for whom he writes a review, and that creates the conflict of interest. The only solution is to raise this question, to raise the question that it is necessary to blind the requests for reviewing. So the reviewer is not supposed to know anything about you. He should look only at the trial you are submitting, and he should be looking only at the article that you have sent. So very many people speak about it, and I'm sure that one day this blinding will take place. So what can be done? So when submitting your request for the grant, you choose the field of knowledge. and that depends, and including codes of classification, and that will influence on the way of your request to what profile expert this request will go. So the field, for example, is medicine, and then specialties, surgery, cardiology. You should be very specific about it. So you choose, for example, 2, 3, so that you would get to your reviewer. If you have won, I will tell you what is to be done to be on the good side. So, because winning is not all. So you get a grant agreement from the fund, and this agreement, they state, please indicate how many articles in Scopus you will publish for 3 years. The President's Fund asks it even at the time of the grant submission, but never, no matter when this question is asked. For this grant, suppose you ask, so, and I will advise you, in the first year, do not write any articles. You may write them, but don't indicate it in the agreement. Indicate 0 articles. Second year, 2 articles, and the third year, 6. So second year, 30% of articles, and the remainder will be written during the third year. Excellent. If you publish all 5 articles, if you can do it in the first year, it's okay. You have fulfilled your obligations. But, you know, I was in the situation when you write an article and you could not publish it in the first year. But fund receives not only published articles, but those that have already gone to the press. Sometimes refuse, decline, and you can do nothing. It's a frequent problem. That's why don't brag in front of anyone. The grant is yours. Nobody will take it away. That's why it's better to write that you do not publish any articles during the first year. There is no violation in that, but you are on the safe side. They will understand you. They will understand what you mean. Then solve urgent issues. So an order about the composition of the team on the grant is to be issued in the organization. Then all the overheads are to be put on the organization's books. And you start preparing procurement of disposal materials, because now they are all acquired through auctions. It takes a lot of time. First you take part in the auction, you buy, then they are supposed to deliver it. So it takes a lot of time. That's why you should think about it in advance. And learn the language of memos, because you will communicate with the leadership with memos. Each your step is to be confirmed by a memo. So say, for example, transferring this or that sum to organize procurement, it is all done through memos. That's what I said at the red tape, remember? So what business language is spoken in your company? Go to the CITES site and assign the number NRR to your project. Here you see menu, and you see this list. You choose government registration, then insert your work, insert your paper, insert your project, and here you, for example, the organization has an account with the cities, and so we have a cities number. That's important. RMS requires it. As to the President's Fund, I don't remember, but the RMS, they insist on this number being assigned to the project. Now we come to the publication of articles. Well, we need to publish quickly. We remember about the report. The review of literature is quite possible. Don't be afraid that this is not an original article. The review of literature is also an article, considered as an article, and can be submitted. We get oriented to Scopus W or S, and in each article we are supposed to make a reference to the grant. You shouldn't forget about it. So we mentioned the fund and the number of the grant. So you should mention it in all articles, in review articles as well. The article without the reference to the grant is not taken into account in the report. Now the timing of performance, selection of material, processing of material, and publication of articles. As I told you, and the last article is to be published shortly before the time of the grant is over, because you may continue processing the material. You can, if you have recruited, if you have collected more material, you can start processing after the grant is over. But the articles are to be written before the time the grant is over. I'm still publishing articles on the material for which I got the grant, and I always refer to the grant. So, and that is quite okay. I always refer to the grant in this article. Don't make such mistake as not mentioning the grant. Now the report on the grant, you describe the work that you have done on the project, the research, you describe the results you achieved, and the list of articles. And here they will remind you of the plan that you have compiled at the beginning. So remember that in this plan you are supposed to promise only what you can do. If you have promised, do it. If you have won money, work for this money. And I don't care that you haven't managed to do anything, you haven't time. And they will think whether they will prolong funding for you or not for the next year. So no, if you do not fulfill your plan for the year, you can get into the blacklist. There can be a black mark against you in the list, and you won't get the money for the following year. That's why when we write a request, when we make a plan, we think what may happen if we win this grant. That's all I wanted to say. That probably all is not for the money. You know, the idea is that all the money is to be spent, otherwise they won't give you more. No, you can transfer the money for the next year. and you can spend, nobody will punish you for that. You may write that the funds have not been spent because the agreements has not yet been paid. Or, for example, we leave 2 million from the previous year, another 6 million will come, and we will buy a very, very huge equipment if it is required, very expensive equipment. But if the grant is over, if you haven't spent the money, you are supposed to return it to the fund. So your grant is over. And remember that your labor is to be paid for. That's why don't be shy to speak about remuneration. So I'm ready to answer your questions.
Thank you, Dimitri. That was very interesting. Sorry? I enjoyed your enthusiasm as much as as the contents. The last part of our seminar is going to be devoted to discussion of abstracts and manuscripts. And the first one that I want to put up is a paper that I received this morning. The title, I'm going to make adjustments as I go along. The title is Mentorship in Training of Minimal Invasive Pancreatic Duodenectomy. Okay, the only little detail that I would do is take away the dot from the title. It seems to be a structured abstract with the 4 chapters: introduction, objective, patient and methods and results. 5 chapters, conclusion. I'm not aware of the journal to which this is going to be submitted.
But I can explain. It was the request from American Surgical Association to send an abstract, and the date is the finishing date is 16th of November for the presentation, for the possible presentation during the Congress in April.
Okay. And so Annals of Surgery is the standard, I would imagine, the standard that has to be observed. I don't remember offhand if they have 5 chapters or 4 chapters.
What do you mean?
Well, in the instructions for authors for Annals of Surgery, I don't remember if the abstracts should be structured with introduction and objective, or is it not 1 chapter?
No, there is a special form on site.
Okay.
It's simply an abstract. It's not a manuscript. It's only an abstract for the.
Yes, but I'm not aware of the let's say the format. The format is this: is introduction, 1 chapter.
The format is the title, body of the text, conclusion, and we simply introduced these chapters in the body of the text.
Okay. Hi, Pavel.
I agree with Professor because recently in main journal the aim or objective is included in background. It's something like
if there's nothing specific, if there's nothing specific about that, I would certainly, I think it would be better to put the objective and introduction together, something like this, like here. But what I will do, Igor, is, I'm sorry, not here, here. what I will do is I will look into this and get back to you later on this. Okay, let's put it here. And now read the objective. Get rid of one word here. An laparoscopic pancreatoduodenectomy is one of the most challenging minimal invasive procedures.
Yeah.
The training of which is not standardized, okay? So the objective is, why is this a mistake? It was probably something happened in the typing. Okay, to evaluate immediate outcomes, the goal then was to evaluate immediate outcomes of minimal invasive pancreatectomy, in different types of training. Self-mastering, monitoring by proctoring on site. Okay, I've read the patients and methods. What is a little bit surprising is that you are actually comparing 3 different types of training. The self-mastering one, the one that was mentored by the self-mastering surgeon, and then the third is the mentoring by proctoring on site. So what in the goal here, we have to have those 3. We have to find some way of getting those 3 types of training into the introduction or into the goal. We'll think about that as we go along. Okay. Now, is there a word limit to the abstract?
Yes, I think that Pavel is with us and he knows this figure much better.
Who?
Pavel Titunik, you know him? I suppose that he's something.
Okay, Pavel,
here.
How many words are allowed? Pavel?
It's not about the count of words, but it's a count of printed, I don't know in English, printed, как знаки будут, letters, commas, dots, and something like this.
It's characters.
Yeah, characters, yeah, of course.
Oh, okay. So how many characters?
1,000 and something else.
Yeah, well, we have to know. It's going to say 1,001 or 1,999.
I don't know, but the guys.
Yes, I think that Pavel is. He knows this figure much better.
Who?
Yes, sir. 1,750.
1,750. Okay.
1,750.
No, the words in my computer I have 320 words, but I don't have a way of counting the amount of characters.
1,000 and something else.
750.
1,750. 1,750.
I don't know, but the guys.
Yes, I think that Pavel is
one.
He knows this figure much better.
Yes, sir. 1,750.
Yes, I understand that, but I don't have a way of counting that on my computer. So we'll figure that out afterwards. Okay, so patients and methods. Okay, so there's something else that we have to consider. How many times do we see minimal invasive pancreatectomy duodenectomy in the abstract. We see it several times. So maybe it would be, if it's allowed, it would be interesting to abbreviate MIPD, for instance, here. And then we could do it here, MIPD. Oh, I'm sorry. MIPD.
The thing that I'm thinking about, perhaps it will be it may be good if we mention that in the objective, different types of training, self-mastering, mentoring by property on site. That all three surgeons are working in one institution.
Okay.
So in one institution. In the single, it's in the single institution.
Yes, there's different types. To evaluate immediate outcomes of 3 surgeons performing
perhaps simply in outcomes of 3 surgeons. With the different types of training.
Oh, let's see. See. Okay, so we have to find a way of categorizing the third type. We have self-mastering for the first surgeon. We have let's see.
We thought about this very much. So the situation is the following. So the first surgeon started it without any training, any specific training.
Right.
The second was involved. He assisted during all the operations that we performed and started performing by himself different parts of the operation after the general experience of 50 and began performing it by himself after general experience, I don't know, 80, something like this. And the third surgeon, he was involved sometimes in assisting, but he's simply working in one hospital. He simply saw a lot of procedures being in the operating room and so on. So he didn't such experience, for example, of assisting in 50 operations. He assisted, I think, 10, 20, but he spent a lot of time watching these operations. And so he's in one team. He's working in one team and started doing this in one team.
Yes, I understand. So the self-mastering is the first. The mentoring by proctoring on site is the third. We have to find something to categorize the second. We'll think about that and come up with an answer later on. So I understand that. Yes. Okay. So patients who underwent MIPD, total lap
So the other thing, Ava, I would like to say, because it's really, we spoke much about this. So the third surgeon, he performed hybrid procedures and he performed everything by laparoscopy except pancreatic duodenostomy. So he makes mini laparotomy for this, and he performed pancreatic duodenostomy by traditional suturing through mini laparotomy.
Okay, so which is different from the first two surgeons.
Yes, first two surgeons performed total laparoscopically.
Okay. Well, we have to, let's say, we'll put that in someplace else. Okay, from generated to the were identified through an initial. Okay. I would suggest that the patient numbers, this is nothing that was selected. It's part of our population. So I would say how many patients altogether?
404.
404 patients underwent, 404. 404 patients underwent MIPD. .5 male. Okay. Median age 62. Okay. Median AS score 2.3. Median Charlson-Dixon score 1.7. We'll put this someplace else. We'll see where to put it. Let's leave it like that for the time being. And
perhaps we can exclude months. Perhaps it doesn't matter from 2007 up to 2021.
I would say, let's say, well, how many years is that? 7 to 21 is 13. I think it's important to say yes, let's say where it is. During this way, it doesn't count as any words. And we start the sentence with a word rather than a
figure.
Figure. So we have 440 patients underwent, and this probably is not important. I don't know if you agree. Can I?
Yes.
Can
yes,
I?
Absolutely. Right.
Yes.
We spoke about this yesterday also.
Okay. Then we can say the procedure was performed by 3 different surgeons, and then here perhaps total laparoscopy.
We have this information below.
Sorry?
It seems to me that we have this information below. It We tried to describe it shortly, that about first surgeon, second surgeon, and so on.
Here.
No. The next line.
The next line here.
Yeah.
Yeah, but that's a training. All I want to say, you said that it was important that the first two did total laparoscopic, whereas the third did a hybrid procedure.
There is such information in the next lines, you see. Now, the third surgeon is training by proctoring on site and performs the procedure by...
Okay. So then, but they started that. Okay, but we haven't mentioned that the first one did total laparoscopic.
The first surgeon started performing the total laparoscopic procedures. Perhaps it may be like this.
Yeah.
The first surgeon, yeah.
Right. The first surgeon started
performing total laparoscopic minimally invasive.
Yeah.
Total laparoscopic MIPD, something like this.
Yeah? Total laparoscopic
MIPD.
Well, minimal invasive means laparoscopic. So
PD.
Without previous
specific training program.
Yeah. The second, no need, we talked about this yesterday, there's no need to repeat surgeon because we know we're talking about surgeons. The second, assisted the first for 50 procedures before performing
his first,
exactly, his first 10 procedures by himself under the mentoring of the experienced surgeon, of the first surgeon, of the or the more experienced, maybe. The third surgeon was trained by proctoring on site.
And performed everything last year.
Right. Sorry? I didn't hear.
Yes, no. I mean that everything in the past, yes, and performed. Not before.
Yes, because it's already done. Performed the procedure by a hybrid technique. The first 40 consecutive minimal acid procedures for each surgeon was analyzed by custom and RA custom methodology. High-risk patients were determined according to the UA. Is that a capital UA or not?
It's not a capital.
Not a capital, it's UA like that. Okay, I am not familiar with that. Okay. Results Let me just correct this thing here. First was form 257. The second, $122, and the third, $43. The number of high risk, this high risk, right? You said high risk here?
Yes, yes.
Okay, so the number of high risk patients, always the same term for the same word, was greater for the third surgeon.
So, Eba, it's important to know for interpretation that all these differences, all these differences are not statistically significant,
Yes.
except the last that is mentioned in the last lines of this chapter.
Yes. Okay, that's okay. We will take that into account. Yes. Okay.
Perhaps from this point of view, I think that perhaps it's not necessary to mention that it was greater for the third surgeon. Perhaps we should simply show the figures. So, like the number of high-risk patients was
was
1823, median operative time, then severe morbidity, and so on, and then simply the conclusion. I mean, that the last sentence, that there was no significant difference in all perioperative data except the blood loss.
Absolutely. Absolutely. Okay. So it's okay like I just wrote now?
Yes. I think so.
All right. Median operative time was 422. The same thing. Median operative time was 422 minutes. Okay, 427 and 577 minutes. Okay. And then all we have to do here is respectively. Get rid of a lot of words. Why is there an exclamation point there? Is
I
that
think it's simply a mistake.
Mistake, okay. Severe morbidity. Severe morbidity was evaluated to Claviandendo is a method.
First, was should be removed. Severe morbidity evaluated.
But it belongs here. And then here, where you say morbidity, class or grade, I think it's grade, right?
Mm-hmm.
Was 24% respectively. Intraoperative blood loss was again respectively. Okay. There was no significant difference in all perioperative data among the 3 surgeons except the blood loss. Okay. Okay. Question, you said you analyzed the custom mortality, but I don't see any results. What were the results of the custom?
Do you think we should insert the table with the results?
Where is the table? Do you have the table? Oh, they don't have it.
A lot of them.
Okay, well, no, the problem is in an abstract, if you mention something in the methods, that we have to have a result. So you have to have at least one sentence about the methodology. What was the result of the custom? Can you just summarize?
All the results were so I don't know how to say it. It's the reduction analysis. So the results were compared. I don't know how to explain it. So like we compared the first 40 procedures for everybody.
Yeah.
So
what method did you use to compare them?
So this method Kusum, so we have special statistic. So we didn't do it by ourselves. So it's professional statistics did it.
I understand.
He brought a lot of tables with all the parameters that we.
Yeah, but you have to mention that. I would say the first 40 consecutive MIPs for each surgeon was analyzed by custom and RA custom methodology and compared by, I don't know what. You say you have to mention the statistical test here.
I think compared by, so we should ask how it is, what is the correct name. Pavel, do you know?
Okay.
That is very right question. Thank you, because QSUM is used to determine the length of the learning curve, but nothing else.
Yeah, so I understand that. The custom is to find out where the curve starts to level off.
Yeah.
But that's for each individual surgeon that the custom has a learning curve.
Yeah.
And now what you wanted to do is to make sure that the learning curve was not different between the 3 surgeons, is as far as I understand. Is that true?
So we can
the
use
learning curve was similar. There was no statistically significant difference in the learning curve for surgeons.
Yeah, exactly.
Okay.
We use Mann-Whitney to compare the data on continuous data with Mann-Whitney test. I think that is, but we should
it was one.
Was the decision?
Okay. What did you do? Did you compare is there a specific? If you did a Mann-Whitney, that means you did it's a non-parametric comparison of the means.
Yeah, of course.
Yes. Okay. So they have to mention that. Is that where it should be there, Mann-Whitney?
I think so, but I'm not sure. We should clarify. This,
okay. Let me put it here, and then you clarify it.
Well, can you say something because you have the best contact with this statistician?
It was Mann-Whitney test.
It was
It was man-Whitney test.
Man-Whitney, right? Okay.
Yeah.
Mm-hmm.
Hey, Professor, should we put the information about the length of learning curve, duration? Because there was no differences, statistical differences in the length of learning curve.
What was the learning curve based on? What was the endpoint?
I think it's.
I think it may be very difficult here because it may be some like separate study.
It depends on the outcomes which is estimated. It may be one number of patients.
But I think it's an interesting notion to say that the learning curve, that there was no statistical significant difference between the learning curve of the three surgeons, but still there was a decrease in the blood loss. But it depends on what the endpoint for the custom was. Was it the timing of the procedure? Was it what was the endpoint for the custom? How did you determine when the learning curve was over?
It's a question.
No, I think that in this study, in this work, we didn't determine the final point of learning curve. We tried to do detecting the minimal time for each surgeon which he had need for in his practice, how many procedures he need to do in order to reach the minimal time in his practice. But it's simply different because we say in the previous work, which was published in surgical endoscopy when we compared learning curves in robotic and hybrid technique from 3 centers. So the learning curve was about 60, 70 procedures. It was 67, something like this. And so the third surgeon with his 43 procedures, I think that he is only in the middle of his learning curve. So I think that it is hard here to speak about learning curves.
So maybe you should take that out. You want to take that out?
What do you mean? To take out the third surgeon or to take out the learning curve?
No, take out the learning curve in this paper.
Yes, I think so. I think that we can simply compare the experience of 3 surgeons and simply to compare the basic perioperative data, but we are forced to reduce it to the experience of to the minimal experience in this group. But it seemed to us simply interesting because there are a lot of manuscripts that, not a lot, but there are some that discuss the way of mentoring in laparoscopic PD. And Besselink is doing, and about robotic is publishing much about robotic training and so on. So to our experience, it is very important, the involving of surgeons in this practice. So that was the reason that we tried to show our experience and to try to...
I understand, Pavel, can I ask you to send me the PDFs of the papers that you used for this study on the papers on training? Can you send me the PDFs, please? So that I can look at them and get an idea. And then I will...
Abe, I'm sorry, can I speak?
Sure.
So the idea was that all the papers, they discuss how to train the surgeon who comes to pass through some special program in the clinic. And this training is short. It can't be long. It may be 3 days or a week or a month, but not longer. So, and we simply show that it is very important to be involved in the process, and when the surgeon is involved and if he is educated to one clinic, I think that it's something like we have such experience from Herbert Zech, who trained one of his assistants, and now she's very experienced in robotic PD. So and the conclusion is, you see, that we think that proctoring on site should be included in training process of LPD.
Okay, yeah, I understand that.
The message.
I understand that. But I would not exclude the custom right off from the start. I would like to, if once again, Pavel, if you can send me the PUSM results so that I can take a look and see if how we can include that in. It might be, I think it might be interesting to say that in spite of the fact that the learning curve, you say that there was no difference in whatever endpoint you're talking about between the three surgeons as far as the time necessary to level off, even though it was individual, level off on having the same time to perform the operation. Is that correct?
Yes.
Okay. It's interesting to know that in spite of the fact...
Abe, I'm sorry, the same time for the first 40.
Yes, I understand. Yeah. The same time for the first 40. I think it's interesting. Yeah, okay. So if it's only for the first 40, then it has probably less influence on the blood loss. I'm trying to find, what I'm trying to say is I'm trying to think of why the custom learning curve could be a factor that determines, that intervenes in the blood loss. If you feel that it does not, and then we should exclude it from the methodology and the results. However, if it's a factor that might contribute to the blood loss, or at least explain that the blood loss comes from something else rather than the learning curve, then it should be here.
Maybe the blood loss was the endpoint of the QSUM, because it was different plots for every different endpoints.
Okay, so then include. So then, okay, good remark, Michael. So then, all we need is the custom methodology only for the blood loss.
Yeah, for the single factor.
Blood loss.
We use this methodology. I'm sorry. So we use this methodology for each of the parameters, and saw that it shows the difference only in blood loss.
I understand. So now I'm trying. I understand much better. So
that is the reason that we have a lot of tables. We have a table.
Okay. All right. So then what we have to do, I think, is to say in the in this here, the methodology, the first 40 consecutive MIPDs was analyzed by customer compared by the person according to, and then we're going to put the endpoints that you found. 1, 2, 3, and those 1, 2, 3s are going to be the number of high-risk patients, the median operative time, some morbidity, and blood loss.
And blood loss.
So that means it's only going to be 4. Those are the 4 relevant custom herbs. Is that okay?
Mm-hmm. Yeah.
Okay, I would put then high-risk patients here. Okay, now, the number of high-risk patients, the median operative time, respectively. Okay, so now we have the result of the custom. The number of high-risk patients, the median time, the morbidity, and then the blood loss. Okay. Now, the conclusion is proctoring on site reduced intraoperative blood loss.
During minimally invasive.
Yes, or minimal invasive instrument for something like that.
It may be the promising way of training, but needs the future evaluation.
Sorry?
The proctoring on site may be the promising standard or way of training for lab PD.
No, I think that we recommend is a good conclusion, no?
Well, there's two ways of saying it. Like Eva says, we can say that we suggest that on-site proctoring be further evaluated and then be included in the training process, or would you want to recommend it right away? I would think that you'd have to be a little bit more general and say that we suggest that on-site proctoring should be further evaluated and eventually included in the training process, something like that.
Yes.
Sounds good, yeah. Should be evaluated.
Yeah.
Yeah, it's very good, yeah. Thank you.
We I don't know how many characters, but we're down to 301 words.
I'm sorry. Do you think the conclusion should be perhaps more concrete, not evaluated potentially, and perhaps should be further evaluated and included?
Not potentially.
Yes,
Okay.
it's a little bit forced, this statement.
Yes. Okay. Okay. I don't remember how many words did we have to begin with, Pavel? Do you remember?
1,750.
No, how many words were there?
Characters, yeah.
I don't remember how many words. Well, anyhow, well, we have to, do you have a way of counting the characters?
I think there is a special program.
There's a special program to do that. Okay.
The computer.
Yeah. Okay. So what I suggest is that I think Pavel is going to do this. So Pavel, you have to fill in this part here. You see it on the screen on yellow. And then here also. That's the only thing that's missing.
Professor, may I ask you?
Yes.
The cutoff values, you mean there is a number of patients for every factors. I mean, for blood loss.
That's a little bit of a it's a little bit of a problem for me, because for me, the custom methodology is not. That means that you obtained the endpoint that you're talking about before the first 40. Is that true?
Yeah.
Because why, if you have a 40 for everybody, that means that your endpoint, whatever the endpoint was, in other words, morbidity, operative time, operative time, let's say operative time, it is only 3. Operative time, morbidity, and blood loss leveled off before the first 40.
Yeah. Within the 40.
Within the 40.
Yeah.
That's true.
Maybe it's enough to include about the cutoff values.
Yeah. So maybe instead of, we would say the, I don't know what's the expression? I have to remember the expression. There's a special expression for custom. Something like the level of, let's say, operative time, morbidity, and blood loss was measured during the first 40 consecutive procedures analyzed by customer methodology and compared. So then we get rid of this. But the level off. There's a term. There's a specific term for that, Pavel. You have to find that term when the curve breaks off. Okay.
We will discuss with our statisticians. Yeah, and I think we will find the proper way to.
There's a special word for that.
Yeah. Mm-hmm.
It's not cut off, and it's not the level off. It's something. There's a very special when the slope. It's when the slope levels off.
Yeah. Of course. The change in the slope.
Slope, yeah. Or the critical. Let's say the critical. I'll put the critical slope, and you change that as necessary. Okay.
Maybe.
I don't know what it is. It is a special thing.
Yeah, of course. Yeah.
And so look at the values we can use for that was for this. So it's only 3 because we don't. The morbidity should be out. The number of high risk patients was not part of the custom, right? So that goes here.
It's a part of risk adjustment custom. So
yes, but it doesn't have anything to do with the custom.
Yeah, of course. It's not the result.
It's part of the population, but it's not part of the custom.
It's not. Yes.
Whereas the other 3 parameters, in other words, the time, the morbidity, the morbidity is not also. The morbidity is a result. Did you determine the custom according to morbidity as well?
Yes.
Yeah, but the type of the slope is different, completely another.
I can imagine.
It's like I don't know.
No, we simply summarize. So unite all the complications from 3A to 5, grade 3A 5, and then they were analyzed. I understood that with this custom analysis, but they were on the experience of first 40 operations, 43.
Okay, I still don't understand why how did you select the first 4? How did you select 40? Who did the selection?
Because the minimal experience of the surgeon in this team is 43. So this special analysis, as I understand it, and as we made the task for our statistician, it's.
But yeah, the minimum, the what do you mean? The average for all 3 surgeons was 43?
I think no.
I don't understand.
Fortunately, the QSM plots, the changing of custom plots was within the 40 patients. Fortunately for
that's what I understood. Yes.
Yeah.
Why did you choose 40?
I think that was the point of changing the plot. Am I right, Pavel? No? We should clarify. We're missing our statisticians just now.
Okay.
I am sorry to interrupt. This is your translator speaking. There is a message from Kira in the chat.
Yes.
Yeah, so Kira is saying that basically there is a function in Word. If you look on top, you will find a review tab. If you click on the review tab, there is a word count function, and that will give you the number of characters as well.
Where is that? Sorry. In the word?
For all custom plots, the
review tab, you find review, and there'll be word count. Click revision, maybe it is called revision in yours.
Yeah, revision.
There
yeah.
should be a word count. Well, that's not word. There should be word count in the English version. There is a little thing that says word count.
Yeah, I don't see it though. In what menu is it? A drop-down menu? Is it? It should be the same format. Yeah, no.
Please ask me to translate what's written in the chat.
Yeah, maybe.
Maybe here.
There it is.
There it is. Yeah.
Yeah. Okay. So. Come on. Okay, so Pavel, you see the word count, the character count with or without spaces. Do you know whether the 1,750 is with or without spaces?
Without spaces.
Okay, so we're good. We have 1,674. Okay, good. You note that down? So that means even we have room for another couple of words because 750, we have another 70 or something words, characters to deal with. Thank you very much, whoever made the suggestion for the word count. Whoever made that, thank you. Let me see.
It was Kira, I see it in the messages.
Yes, okay. Thank you, Kira. Okay, yeah, and as a matter of fact, we have to fill in this thing, so there might be some more characters there. So what I would suggest, and then let me suggest something here, Parol. If you put this, get rid of the space here. Well, no, it's not going to count in the characters. Yeah. Okay. Oh, what is the AU-FRS score?
It's a prognostic
scale which.
Yeah, but did you? Where is the result?
So there are no results. It's prognostic score that evaluate the risks of pancreatic fistula in postoperative period according to the characteristics of the pancreas, of the diameter.
Why don't you just say that severe morbidity was evaluated according to Clavien Dindo, and that high-risk patients were those who had 3A or over.
So we can exclude this thing because we included it because we simply thought we tried to compare the group of patients for each surgeon and to understand perhaps because the reason for more number of complications may be because he operated more high-risk patients and so on. So that was the reason. Perhaps we simply can exclude it from the abstract.
So is it okay like that, what I just said here?
No, dear professor. High risk is mean no complication. It's a prognosis.
It's a prognosis. Okay,
it's a prognostic scale that we evaluate before the operation.
Yes. Okay.
Simply the characteristic of patients.
Yeah.
That are going to have a surgery.
Okay. Yes, I understand.
I think that we can exclude it from the abstract, and we can discuss it. For example, if we decide to make a manuscript, or in the talk somewhere, so we can describe.
So I take it off the high risk patients, take out the high risk.
Sorry?
Should I take the high risk patients out?
I think we can do this because it's simply, so it's for us. We didn't have statistically significant differences in the patients that were operated by each of these three surgeons. But
I understand, but the number of high-risk patients, rather than saying the number, you should probably say the percentages. 16 out of 257, 18 out of 120, and 23 out of 23. We're talking about 50% here, whereas here we're talking about less than 5%. Are you sure that there's no statistically significant difference between the percentages? Pablo?
Yes, I also was surprised, but our statistician, he said yes.
This is 16 out of 257, 18 out of 120.
No, it's within the 40 patients. I think the first 40.
Yes, it's the
initial experience
after.
Ah, okay, within the first 40. So that's why it's not statistically significant.
Yes.
Okay.
Yes.
Okay. Yeah, but that's not clear. That is not clear. The way you have the way you've set this up. I would probably agree with Igor that you should probably take this out of the abstract and explain it when you get the paper accepted and something like that. It makes things too confusing here.
We simply decided to put it here because simply to show that we were thinking about this.
Yes, I understand. But it makes it very complicated because if we put it in the methods, we have to have a result. And if we have a result, we have to explain how we got that result. So it's I would suggest taking it out.
Yes, it seems to me that we can take it out from the abstract.
It was like an explanation for the difference, non-statistical difference in the outcomes, because you see that in third surgeon, the rate of severe morbidity was.
What would be of interest if however, if the fact that 23 out of the first 40 for the last surgeon was much higher than whatever the values were. I don't remember them anymore. If I put them back, they would be here, here. So you have 16 out of 40, 18 out of 40, and 23 out of 40. No, not a big difference. Okay. Yeah. So get rid of them. Get rid of it. Okay. What would have been of interest is if that, for instance, the third surgeon had had more high-risk patients, and in spite of the high-risk patients, he had less blood loss.
Yeah.
So that means that's another positive point for the proctoring in favor of the proctoring, on-site proctoring.
Exactly.
Yeah, but maybe you can bring that out if in the paper. That has to be brought out in the paper as a possible reason, even though it was not statistically significant.
Yeah.
Okay, does that? I think we're off to a good start here. So Pavel, where's Pavel? Oh, here, it's over here. You changed your spot on my screen.
On my also.
Okay. So can I ask you to complete the results? Find
Yes, of
the
course.
exact word. Yeah, find the exact word for the cutoff or the critical slope, whatever you call it, in the custom curve. And then send me the PDFs of the other papers on training.
Okay.
If you can do that this evening for you and this afternoon for me, so that I can work on that tomorrow and get back to you sometime Monday. Can we plan Monday? I have another teaching course. When would you be free on Monday?
I will. It's up to you. So I will be free when you're free.
Yeah, but it might be something like 8 p.m. for you. Is that okay?
Yes.
PM.
Okay. So can you set up a Zoom conference between the two of us for Monday at 8?
Of course. Of course.
You send me the link, okay? And we'll work it out on Monday. Is that okay with you, Igor?
Yes, thank you very much, Abe. So I have a meeting in the department at 7 on Monday, but I hope that I'll try to finish it at 8 and I'll try to connect through the phone.
Oh, if you want it 9, it's okay. It could be 9. If you want it to be later for you?
It's better for me.
9?
Yes. 9 Moscow time, I mean.
Okay, 9 p.m. Is that okay, Pavel?
For me?
Yeah.
Of course.
Yes.
I will try to understand because I will be in my vacation in other sports, not in Russia.
Ah.
But I will do my best to join this conference.
Okay, great. Okay, so we'll all meet again on Monday evening to talk about that. Okay, great.
Hey, but I'm sorry. The only thing that I would like to ask, because there is the last day of acceptance of these abstracts is the 16th of November, so it's Tuesday.
Yes.
So
you want to do it Sunday? Tomorrow?
As for me, I can't do it, but it's not a problem. We can do it on Monday. Simply, it will be the last day when we should meet.
Yes, I understand. It's up to you. It's up to you. I can do it tomorrow, but I can't do it during the day of Monday. I'm teaching all day Monday.
No, it's not. I don't want you to disturb on Sunday because you are working so much. I see that I didn't have the possibility to be all the day, but I see how you're working, how the great work simply. So I simply.
No, it's okay with me. If you want to do it Sunday, I can do it Sunday. It's just we have to have the time to do the work. And anyhow, Monday I can't work Monday because I'm teaching all day. So Sunday evening would be okay with me if that's okay with you.
No, for me it's okay, but again, I'm simply. It's not a problem. Monday evening, it's also not a problem. We can do it, and
whichever
it's up to you. We will do it.
Well,
like Pavel said.
How about
recording in progress.
Pavel, you send me all this information. I will try to look at it and try to make an estimation this evening for me. It may be late for you, but you'll get the message tomorrow morning. Whether it seems to me that we have a lot of work or not a lot of work to do. If we have a lot of work to do, a lot of work that you have to do, we'll put it on Monday. If you can get this done quickly, either this evening or tomorrow during the morning, then we can do it on Sunday.
Okay, I do my best.
Is that okay with everybody?
Yes, of course.
Yes, yeah, sure.
Okay. Okay. I hope everybody was able to take advantage of the composition and how we reword and how we rephrase, how we got the principal points as far as the teaching aspect of the medical writing here is, let's say, combining two chapters in the beginning, making sure that methods was only methods, results was only results, and then a one-to-one correspondence between everything that we did in methods. We have to have a result. Everything in result, we have to have a method. And then the only statistical significant difference that we found was in the blood loss. And this leads us to make the recommendation that on-site proctoring might be a valuable tool for training. Because of that results, we suggested it be included into the program, the training program for minimal invasive PD. And that looks like it's okay. Pavel, we can get rid of a lot of characters here as well. What I'm going to do is I'm going to send you this abstract as it's corrected. Okay? Mm-hmm. So you can use it as we can have here. You get rid of characters this way. Okay? So now we might be down to, actually increased. 1,700. We're still under the 1,750. Okay? Can you see that?
Okay.
Okay, good. So we have a little bit less, you have to finish the sentence with less than 40 characters. Think you can do it? I'm sure you can. Okay, good. So we'll talk about that tomorrow, okay? I'm waiting for your email.
Yeah, and what time is more suitable for you?
When? Tomorrow?
Yes, tomorrow.
Tomorrow, the most suitable would be about 6 p.m.
Okay, 6 p.m. your time, yes, European?
Yeah, 6 p.m. my time, 8 p.m. your time.
Okay.
Is that okay?
Yes, it's great.
Okay, and that's better than Monday for you?
It's better than Monday from the point of view that we will have more time for some corrections if we need.
Yeah, but don't forget that Tuesday, is it what, Tuesday, midnight, Tuesday? Midnight in the United States.
It's simply 16th of November and that's all.
Yeah, so it's probably 16th of midnight. So that means you'll have all day Tuesday to work on it.
Yes, I think so, because also we have, I think, from 7 to 9 hours difference between.
Yeah, sure.
7 and more. So
what we have to do, Pavel, is to make sure Monday, you have to find out if the cutoff, the deadline is midnight on Tuesday or not.
Okay.
I'm sure it is, but just check. If you like, either Pavel or Igor, send me a email correspondence to whoever is organizing that. I think I know who it is that's organizing that. I will send him an email today to find out if the deadline is at midnight or not. Okay.
So now I'm looking for the message. So it's simply deadline November 16, 2021. That's all. No, after
who
submission
signed that?
deadline, yes, it's 11:59 p.m. European time, ET, Eastern time. I think.
Eastern time. That's oh, it's written. Yeah, so it's midnight. It's 1 minute before midnight at the end of Tuesday.
Yeah.
Eastern time. So that must be about at least that's 8 hours from Moscow time.
So we have Tuesday for working.
So you have all Tuesday until Wednesday morning at 7 a.m.
Okay, then we can not.
We can
plan
do
the meeting on Sunday, and you have a rest. And
okay, we'll do it on Monday then.
yeah.
All right. Okay. Is that okay with you, Pavel?
Yes.
We'll do it Monday.
Yes.
Okay. And the best time Monday for me is going to be well, actually, Monday, 6 p.m. for me would be good. 8 p.m. for you. No, Igor has a meeting. So 9 p.m. for you, 7 p.m. for me, Monday.
No, it's okay. I perhaps I will be free at 8:30 because the meeting is at 7. So I don't think that it will be longer than.
Okay, so let's leave it free. When you are free, you tell Pavel, or you give me a call, and then we'll hook up.
Okay, great.
Okay, I will be available anytime after 6 p.m.
Okay, then we will send the message on WhatsApp. Is it okay?
That's fine, sure.
I mean the connection there.
That's very good. Okay, very good. Okay, great. I think we have about what time is it in Moscow now? It's 4:30.
Half past 4.
So we have another hour to review another abstract. This one. Now can you see it?
Yes.
Okay. So is Dr. Sherov among the participants here?
Коллеги, извините, автор, к сожалению, не сможет к нам присоединиться.
He can't, the author cannot join us, but his professor is here, and he will take part in the discussion.
Okay. The first question that I have for this paper is, why did you put learning curve into the title? Why is learning curve in the title?
We try to discuss a learning curve in hernia surgery. Maybe article devoted the discussion. It's not a review. It's not an original article.
Yes, I understand. So, first of all, is it it looks like a narrative review? Is that correct?
Yes.
Okay. I would suggest putting that in the title.
Yes.
Okay. And just say learning curves. Is it only in the training or is it in abdominal wall surgery?
One more, please. I listen, but no, some words.
Okay. Is it the learning curve for the training or for the? What was the learning curve for?
For the training.
For the training. Okay. Okay, and what was the end point for the learning curve? That was obviously it was not the same for all the papers in the literature. They're very different.
Yes.
Yeah. So how did you compare that? How? I don't understand what your goal was. What is your goal? I didn't see any goal here.
Excuse me. It's a bad listening.
Maybe the translator can ask you then, what was the goal of this study?
The goal of the study was a mixture of literature review and our own experience.
Yes, but you're talking about a learning curve. How did you determine your learning curve?
It's a question. What is the learning curve in hernia surgery, abdominal surgery?
So is that the goal of your study then? To determine is the goal of your study to define what the learning curve is in surgery? The sound is bad. Okay. No, what I'm trying to find is, even if it's a narrative review, we have to have a goal.
Даже если это описательный обзор, все равно должна быть...
It's a discussion.
What do you mean, a discussion?
Discussion about what is necessary learning curve to train enough to...
Okay, is that the goal of your study?
It's not our study, only our. It's a mixture.
Yes, I'm trying to understand what the goal of your study is.
It looks like literature review, like systematic review.
It's not a systematic review. It's not, there is no enough for a systematic review. I see.
Now, I would say it's a narrative review, okay, but what is the goal?
The goal is to discuss what's necessary to reach enough experience in abdominal wall surgery, hernia surgery.
Could we not say? So, what did you find? What was your result? What was your outcome here? What did you find?
We find that in order to reach enough experience, we should make mixed, not only simulator, but clinical experience.
What was your endpoint for the learning curve? It was a time to operate, operating time?
No. We don't discuss only time to operate. We can discuss the quality of operation. We discuss what's enough.
So how did you determine the quality? I'm listening.
This work during 2 days for in such intensive manner, it is quite hard to review the manuscript with quite big manuscript with a lot of with this interpretation, with the use of interpreter. It simply, I think that it will. Yeah, просто, Abe, I'll say some words in Russian because
okay.
I simply. Я просто думаю, коллеги, я вот так с огромным.
Colleagues, it is with great respect and admiration, looking at the work that Professor has been doing for these 2 days. We understand that it is really very hard for 2 days to analyze, not only to deliver lectures, but to analyze with the abstracts so seriously. I think since we have very little time until the end of the conference, with the use of the, and to discuss this article using the translator, it won't be very effective. So let us discuss what shall we do. I don't want to overload the professor to discuss such a long article with the translator. I quite agree with you, Igor Evgenievich. I am very sorry for not getting prepared in the proper way. I'm very sorry. I would hate to interrupt it, but still this is very hard work. This work will not be effective to discuss such a long abstract through the translator.
It's not even an abstract. It's it's a whole paper. There is no abstract. There is no abstract.
Просто вот еще раз, при тех сложностях, ну вот...
Given the difficulties with communication, it won't be fast. We won't be able to finish it within an hour. So...
Certainly, I agree.
I will be at the Congress in 2 weeks, if I'm lucky. Probably I will talk with the professor and we will try to arrange one more course in the near future.
Okay, very good. Yes, absolutely.
And we will start where we stopped today.
Yes, okay, very good.
I don't understand how the interpretation is working.
Yes. Okay, that's a good idea. I agree 100% with that.
Oh.
And in between time, I would ask the author, Sherov and Andre, whatever your last name is, I don't remember, to work on that paper according to what we have done in the last 2 days. I'm sure that Ruslan has learned a lot from what we have done in the last 2 days. So he can improve this paper and then write an abstract. We have to have an abstract, and then we will be able to move from there. Is that okay, Andre?
Yeah.
Okay.
Very much, dear professor. We want to decide with your help what is the goal of this article. A discussion,
exactly.
Only discussion, maybe a review, not systematic review, of course. And you help us, of course. Thank you very much.
Cesar, I'm willing to do so, but you have to put that into a better form because it's unreadable now. It's very difficult to read now because there's no line of thought. Can you translate that? Are you translating that in Russian?
Yes.
Okay. There's no line of thought. All I see is a let's say just a run of literature. I understand that there's inclusion and exclusion criteria, but what you need to do is to have a specific goal. The specific goal that you seem to want to look at is the learning curve, but that learning curve, in order to be able to be something that we can compare between different reviews in the literature or different papers in the literature, is we have to have a common endpoint for the learning curve. Otherwise, it has no meaning. It can be a time, it can be whatever you want. And then I understand that similar to what we did in the pancreatic study is once you have a learning curve, that you want to use that learning curve as something that should be defined clearly for training in endoscopic surgery and endoscopic hernia repair, and then use that as a standard for the teaching. Is that correct?
Yeah.
Okay. So this is what you have to work on, and we'll work on that the next time that Professor Katkov can organize something with medics. Is that okay?
Okay, thank you very much.
Okay. So if I would then make some final remarks for the participants that are here. First of all, I have to thank everybody for listening for the I don't know how many hours we worked together. Sometimes the talks were a little bit complicated. For instance, I'm sure that the talks on statistics were something that was difficult to follow. I was trying as much as possible to make it as simple as possible, to make you understand that there are two different notions that in statistics, the statistics should not be a problem for medical writing. All you have to understand is when you use descriptive statistics and when you use analytic statistics, when you have parametric and when you have non-parametric tests. That's all you have to understand. But that has to be integrated into your mind so that you do the correct manipulations. And for instance, the most common mistake, as we saw before, is using the mean for non-parametric data. That's very common in all over the medical literature. We have to get that into the mindset of surgeons when they're writing papers. We have to insist on the fact that medical writing style is fairly simple. It's all on the verb. Medical writing style is also based on avoiding repetitions. And you see that when we were correcting the paper yesterday, when we were correcting the abstract today, essentially what we did is we combined words that are the same words in two different sentences. There's always a way of combining them to shorten the number of words. Making things precise means taking away all those empty words. And instead of words, we saw that Michael, we need numbers. Michael was very good at correcting that yesterday. So the three pillars being precision, concision, and clarity. Clarity, of course, comes from the precision and it comes from the concision. Then we saw that the visual aids, the graphs, the tables, especially the graphs, are also very dependent on the type of data, whether it's metric or categorical. As for the statistics, we also saw that the title and the type of study, the language we use for each type of study is dependent on whether we're doing a single arm study, a double arm study, in other words, comparison or not. And when we start doing comparisons, whether it's a case control, whether it's a cohort study, whether it's a randomized trial, we need specific statistical support to ascertain, to determine whether there is any possibility of causality. I think I've summarized in perhaps 5 minutes what we've tried to do in these 2 days. I hope this message is sufficient for you.
You simply made additional talk. Gave, I mean.
Okay.
Yes, Abe, thank you very much. And I think that we should say many thanks for Abe and who perhaps it's better to speak in Russian for me because I understand that interpretation is going.
Yes, okay. Well, then I can listen to it in Russian. Yeah, I can listen to it in translation, yes.
Я просто хотел бы еще раз поблагодарить
I would like to thank Professor Abe Findihat, who really very profoundly explained to us all the aspects of scientific writing. He showed us how we are supposed to work. He gave a very good example of how we should work. I think we learned a lot about it as well. I would like to thank the doctors of the Medical Academy because we have some joint courses with them. Yeah, and so I think this course is really very important for our training practice, and I think we will be repeating. I would like to ask the audience. The audience was quite big. It was not very big, but not 200 and 300 people. So I see the number 17, but yesterday there were about 30. And people just got connected for some time, for several hours. That showed the general interest for what we were discussing. Before I joined this work, I had spoken to Professor Sajan, who also said that Abe had helped them to write an article in a good journal. I think Abraham Fingehat is working throughout the world and helps doctors. And we will continue. Thank you to the organizers. I think the level of organizing was very, very high.
Very good, yeah.
Including informational materials that you spread before this two-day meeting. It was quite clear to everybody what we would be doing, when and how. Thank you very much.
Okay.
And I wish you luck in everything.
Yes, sir. I do too. Yes, okay. Very good.
Thank you very much. Thank you.
Thank you very much, Professor. Good luck. Goodbye.
Okay. Bye-bye.